Dr. Dashrathi Sarkar sir, Chairperson of the Endocrine Society of Bengal, to deliver the inaugural address. Over to Dr. Dashrathi Sarkar sir.
He was there.
He was having net issues.
Dashrathi, can you unmute yourself? I think
he's unmuted.
Oh yeah, now he's unmuted.
But he's having net issues, I think.
Dr. Dashrathi Sarkar sir, can you hear me?
His screen seems frozen. Now it's okay.
Yeah.
Dashrathi, if you're having problems with your internet, you could turn off your video and speak. At least that'll ensure that we get to hear you.
Okay. Let me start.
Yeah.
Yes.
Good evening, everybody. We are all passing through the devastated second wave of the COVID-19. Hope you are all in good health and mind. On behalf of the Endocrine Society of Bengal, it is my great pleasure and utmost privilege to welcome you all in this auspicious evening of the World Thyroid Day on 25th May 2021. More than 200 millions of people worldwide suffer from the thyroid disorders, with almost 50% cases remaining undiagnosed. This has great impact on the health and well-being of the society because most of the metabolic functions are controlled by the thyroid. Creating and raising awareness of the thyroid disorders is the aim of International Thyroid Awareness Week from May 22 to May 28. The theme of this year's Awareness Week is "It's not you, it is your thyroid." The Thyroid Federation International wants to make it clear that the thyroid disorders lead to symptoms that are often misinterpreted by those affected. Our organizing team of Endocrine Society of Bengal, in spite of adverse situation, has extended tremendous efforts to arrange this World Thyroid Day 2021 webinar with a galaxy of eminent endocrinologists of the country. Hope you will enjoy this academic feast. Over to organizer.
Thank you so much, sir. May I now request Dr. Soumik Goswami, sir, Treasurer, Endocrine Society of Bengal, to say a few words regarding award of research grants.
Thank you, Dr. Ajay. For the past several years, Endocrine Society of Bengal has been encouraging research and innovation by awarding research grants to young researchers and young clinicians in the field of endocrinology. We know that we are passing through a difficult phase. There's a pandemic prevailing. And in spite of these constraints, we are very happy and proud to say that this year too, we will hand out research grants to 7 deserving young clinicians and researchers. And to do the honors of announcing the name of these awardees, we have none other than Professor Shubhankar Choudhury. Professor Shubhankar Choudhury needs no introduction, but just to fulfill formalities, Professor Choudhury is presently the Professor and Head of the Department of Endocrinology and Metabolism at IPGME&R and SSKM Hospital, Kolkata. Sir has been the past President of Endocrine Society of India, as well as the Editor-in-Chief of Indian Journal of Endocrinology and Metabolism. Over to Professor Choudhury.
Thank you very much, Soumik. It's a proud privilege to be part of this galaxy this evening, and I can see such senior people as Professor Jayakumar, Dr. Raman Marwa, and I can see Dr. J.J. Mukherjee, and all of you. And it's also a particularly satisfying aspect of the activities of Endocrine Society of Bengal that we give out this research grants, and we do it in a sort of impartial way, as this year's winners list will confirm. So it's not limited only to people who are our trainees in the different medical colleges in Bengal, but from other disciplines as well. So if you look at these names, so I have the pleasure of reading out the names, the topic, and also the co-investigators. The first, of course, it's not in order of merit. I suppose it's in an alphabetical order. So we have Dr. Abhishek Kumar, who is DNB pathology and is currently pursuing his DM course in hematology in NRS Medical College. The co-investigators are Dr. Rajiv De, Dr. Soumik Goswami, and Dr. Shubham Bhattacharya. And the topic is efficacy and safety of zoledronic acid in thalassemia. Thalassemia bone disease, right. So congratulations, Dr. Kumar. You will be handed over the necessary, once you complete the formalities, you'll be handed over the check. Next in our list is Dr. Aditya Deshpande, who is an MD in general medicine, but pursuing his DM in endocrinology in our department at IPGME&R in Kolkata. And our thesis guides or co-investigators for the study are Professor Sujoy Ghosh and Professor Pradeep Mukherjee. And he is, fortunately for this World Thyroid Day program, we have got someone who is trying to take forward research in thyroid disorders, and he will be studying clinical, biochemical, and genetic aspects in congenital hypothyroidism. I think we need more and more data in this field, and I hope it'll help us grow. So congratulations, Dr. Deshpande. Then we have Dr. Debabrata Manna, who is MBBS, pursuing his MD pediatric course in the Department of Pediatrics at the Vivekananda Institute of Medical Sciences in Kolkata. His co-investigators or guides are Dr. Ajitesh Roy and Professor Suparna Guho. He will be studying on bone mineral density, BMD index by DEXA in pediatric patients with rheumatological disorders. So we already have two people studying on bone. We have one studying on thyroid. And we have Dr. Srijit Babu, who is MD in general medicine and pursuing his DM course in endocrinology in our department at IPGME&R Kolkata. I happen to be one of the guides or co-investigators. Along with me is Dr. Rna Bhattacharya, and he'll be again studying Graves' disease. Studying another thyroid-related problem, Graves' orbitopathy, a study on clinical, biochemical, and genetic markers with special reference to microRNA. Congratulations, Dr. Srijit Babu. We have Shushmita Datta, who is MSc in biotechnology, who is a research fellow in our department. Co-investigator is once again Professor Sujoy Ghosh, and she will be taking forward her ongoing work on microRNA, on differentiated thyroid carcinoma, and this time she'll be talking about microRNA expression in differentiated thyroid carcinoma. So again, sincere congratulations, Shushmita. And we have Dr. Abhirup Banerjee, who is MD in medicine, pursuing his DM course in endocrinology at NRS Medical College. The co-investigators or guides are Dr. Soumik Goswami and Professor Nilanjan Sengupta. Once again, it's on thyroid disorders and its effect of levothyroxine supplementation on bone markers in primary hypothyroidism. Congratulations, Abhirup. We have Dr. Kamal Poddar, who is MBBS, but pursuing his MD in general medicine at IPGME&R Kolkata. The co-investigators are Dr. Shantoshil, Professor Shantoshil Pine, Dr. Pranab Kumar Maiti, and Dr. Rna Bhattacharya, and he will be studying hypogonadism and sexual dysfunction in men with alcoholic and non-alcoholic chronic liver disease. Again, congratulations, Dr. Kamal Poddar. May our small effort help all of them to grow and also our discipline of endocrinology to grow. Back to you, Soumik.
Thank you, Professor Chaudhary, and a big congratulations to all the award winners. You will be getting your grants soon after completion of due formalities. Back to Dr. Ajay.
Thank you so much, sir. Now let me call upon Professor Nilanjan Sengupta, sir, Honorary General Secretary of Endocrine Society of Bengal, to deliver the vote of thanks.
Respected Chairperson, respected seniors, dear colleagues and juniors, at the outset, I would like to thank all the prospective audience who would be joining in the webinar. I do understand we all are going through very difficult times, both physically and emotionally stressed. Still, that you will be joining and interacting in this webinar, that is a great thing for us. I would also like to thank all the faculties from all over the country who have agreed to devote their time either delivering the talks or chairing the session. Next, I would like to register my thanks to the entire organizing team comprising of Dr. Soumik Goswami, Dr. Indira Maisnam, Dr. Rana Bhattacharjee, Dr. Parthapratim Chakraborty, who had stitched a wonderful program with luminaries in the field of endocrinology and thyroidology. Not to forget Dr. Dashrathi Sarkar, our chairperson, who is ever encouraging with his advices and positive comments. I would also like to thank Recipe Events of Hardik Chandarana from Ahmedabad for the logistic support. And last but not the least, a word of thanks goes to Abbott India Limited for the logistic support they have provided to this program. So without much further ado, I now pass over to Dr. Ajay Hanumantu, who would now initiate the scientific session, which all we are waiting for. Here we are having a pre-cyclonic weather with rains in West Bengal. It's really a soothing rain till now, not the gale winds yet. So I think you sit back and enjoy and maybe take your attention a few moments off COVID to learn and enjoy thyroidology. Thank you. Over to Ajay.
Thank you so much, sir. We come to the end of the inaugural session. We now move on to the scientific session. I would like to take the permission of all the faculties to record and archive these sessions. Moving on to the first talk. I'll just share my screen here. I would like to invite Professor Debmalya Sanyal, sir, who's the Professor, Department of Endocrinology, KPC Medical College, Kolkata, to chair this session. I would invite Dr. Prem Narayanan, sir, Consultant Endocrinologist and Medical Director, Ahalia Diabetes Hospital, Palakkad, to deliver the talk. Over to Professor Debmalya Sanyal, sir, to conduct the session.
Good evening, and thank you, Professor Nilanjan Sengupta and Team Endocrine Society of Bengal for the kind invitation. And we would be starting with a very interesting and practical topic which we face in our day-to-day clinical practice, that is thyroid eye disease or Graves' orbitopathy, and which is present in almost 50% of patients, but severe orbitopathy is less common. However, the common modality of treatment which we generally use, that is steroid, but still it's non-responsive in about 20% of patients. And especially with regards to extraocular functions, it may not be responsive in 50%, as well as with regards to dysthyroid optic neuropathy, in 40% they may not be responsive. Similarly, proptosis is again a difficult issue with regards to dysthyroid eye disease. But thankfully, we have recent advances with medical therapy, and this may improve the outcomes. So to take us through the advances with regards to management of dysthyroid eye disease, I would like to invite Dr. Prem Narayanan. Over to you.
Thank you so much, Professor Debmalya sir. And also, first of all, thanks to Professor Nilanjan sir, Dr. Partha, and the entire team of Endocrine Society West Bengal for inviting me and giving me an opportunity to interact with all the stalwarts in the field of Indian endocrinology. Without wasting time, I'll just start sharing my screen. Yeah, so my topic for today is newer agents in thyroid-associated orbitopathy. So the flow of presentation would be like just touching up the epidemiology of the tau, the pathogenesis and activity and the severity assessment. Then we'll move on to the immunosuppressants in tau, the biologics in tau, the pipeline and the agents and the supplementary agents with a take-home message. So just a definition, tau is an autoimmune process that affects the orbital and periorbital tissue in dysthyroid states and rarely in euthyroid states also. The epidemiology, the prevalence, many of the studies, it varies. It ranges from 8 to 56%. So there can be ethnic variation. Then the different diagnostic criteria. So all of this adds up towards the varying prevalence of the tau in the community. So this is one study from the SGPGI Lucknow, where 235 Graves' disease patients were screened and 65 patients had the orbitopathy based on the UGOGO grading, and hence the prevalence came up to was 28%. So almost usually even the Western data suggests that 25 to 50% is the occurrence of tau. And in this study, the clinically active case was only 2 cases. So only 2 out of 65 had clinically active case, that is 3%, and extraocular muscle involvement in 5%, and this thyroid optic neuropathy only 2%. And then another article which was published recently last year in the Indian Journal of Ophthalmology. So here also you can see here the male to female ratio was 1.12:1. So the other Western data, it was 3:1. And then the mean age you can see are around 40 years. Then sight-threatening thyroid eye disease in around 7.5%. And interestingly, in this reported study, yes, we can say it can be like a one-center experience only, but hypothyroid and euthyroid patients, you can see that contributed around 54%, and hyperthyroid patients only 46%. So next we just see the pathogenesis of tau. So in the pathogenesis, the few important features will be the cellular mechanism. So which are the 3 major cells involved in the pathogens of tau? One is the orbital fibroblast. Then we have the T cells and also the B cells. The autoantigens, 2 important autoantigens that are involved in the tau are the TSH receptor and the IGF-1 or the insulin-like growth factor 1 receptor. Then the cytokines involved majorly the pro-inflammatory cytokine like the IL-1 beta, then the interleukin 6, interleukin 8, TNF alpha, and even interferon gamma. And the outcomes are 2 tissues are affected. There is orbital adipose tissue expansion can happen, and also the extraocular muscle thickening and fibrosis that results in the thyroid associated orbitopathy that we see. So this is just a pictorial representation. You can see here the orbital fibroblast at the top left corner. So it will express the TSH receptor, and the TSH receptor antibodies can act on the receptor and stimulate the fibroblast, which can interact with the T cells with the CD40, CD154 interaction, and hence resulting in the release of the pro-adipogenic prostaglandins. And you can see here the orbital adipocytes results in expanded adipose tissue in the orbiter. Apart from that, there can be the T cells can also stimulate the B cells in resulting in the increased production of the mature plasma cells, result in the increased production of the TSH receptor antibodies. Then also there can be infiltration of the other immunological cells like the macrophages and monocytes, which can also release the interleukin-1s. And this orbital fibroblast T cell interaction also result in interleukin-1, which can affect the extraocular muscle, resulting in the extraocular muscle enlargement. And then on the other hand side, you can see here on the top right, you can see the IGF-1 receptor is there. IGF-1 agonist acting via the receptor can also release in the interleukin-16, and which again stimulates the helper T cells, resulting in the interferon gamma and TNF release, and again the release of the prostaglandin E2 and resulting in the extraocular muscle thickening or enlargement. And the TGF-beta from the orbital fibroblast can result in the differentiation of fibroblasts into myofibroblasts and resulting in the fibrosis. So this is what in a nutshell the pathogenesis that happens with the thyroid orbitopathy. Even though there are still a lot of players to be identified in this pathogenic process. So this you can see here the orbital adipose tissue with the fibroblast, and in the Graves orbitopathy you can see the expansion of the adipose tissue and also the fibroblast. So based on the various sites of involvement, you can see here the IGF-R written. So there can be the molecule teprotumumab, which can affect the IGF-1 receptor blockade can happen. Then there can be the TSH receptor yet to be identified molecules to block it. So that can also be sometimes be effective in the reducing the orbitopathy progression. Then there can be various cytokines which can be released like the interleukin-6. So the blockers of interleukin-6 like tocilizumab can be effective. Then apart from that, you can see here the post downstream of the IGF receptor, there is a phosphatidylinositol 3 kinase, the mTOR, which can be blocked by the rapamycin, or the PI3 kinase can be blocked by the mycophenolate mofetil or the azathioprins. And so like that, many opportunities are there to prevent the progression of the thyroid orbitopathy. This is Rundle. So FF Rundle, who proposed the Rundle's curve. So what does that suggest? In a thyroid-associated orbitopathy, there will be an active phase or a dynamic phase. And afterwards, when the peak, after the peak is over, then there can be a static phase. After which the severity is not going to progress, only the activity can vary. So this is about the Rundle's curve proposed by FF Rundle. Then the clinical activity score, everybody is well known about this. So just for the revision aspect, at diagnosis, we categorize it or classify it out of 7 based on the orbital pain, gaze-evoked pain, eyelid swelling, lid erythema, conjunctival redness, chemosis, and inflammation of the Karen-Globe plica. Then in the follow-up over the 1 to 3 months, in the follow-up after initiating the treatment, the 3 more parameters will be added, like the increase in proptos of more than 2 mm, decrease in the uniocular excursion in one direction of more than 8 degrees, or the visual acuity reduction by 1 Snellen line. So that will be from 7 in the follow-up, it will be made to, and the activity will be calculated upon 10. Then the no specs, that's the severity grading. Class 0, no signs or symptoms. Then we have the one that is only signs. Then 2 soft tissue involvement, proptosis, extraocular muscle involvement, cornea, and resulting in the sight-threatening stage of the vision loss. So this also usually subgraded also that I'm not going to detail on that aspect. So next we move on to the medical management. So how can we manage these patients medically? So all patients with the Graves orbitopathy, restore and maintain the euthyroidism is the first and foremost motto. Then we'll have to advise them to stop smoking, and then supportive measures like artificial tears can be used. Then based on the UGOGO, we can classify them into mild disease, moderate to severe, and a sight-threatening disease. Mild disease usually does not require any other modalities. Maybe selenium, we have some supportive data on that aspect. Then IV glucocorticoids are necessary only if there is a substantial effect on the quality of the life. Then the moderate to severe disease, active Graves orbitopathy, IV glucocorticoids are indicated. And a patient who responds well, runs well to the treatment, that is good. Then if the patient is not responding well to steroids alone, you can consider the other agents which will be coming into the later. When the sight-threatening eye disease, then definitely the IV glucocorticoids are the one that are the foremost end. And poor response to treatment after 2 weeks, that will result in prompt surgical decompression. So just a few words about glucocorticoids. That is usually the first line agent that is used in the management of the tau with the disease activity. IV has shown to be better than oral, and the immunosuppressive effects can be genomic and non-genomic. It reduces the CAS or the clinical activity score definitely, but not much effect on the natural history or even the reduction in the severity of the orbitopathy. So that is the one drawback. Activity, there's good reduction can be achieved in many of the patients, as already said, around 40 to 50% definitely will be responding, but with the severity, not much reduction can happen with the steroids. Usually, the cumulative dose that we all will be using will be the 4.5 gram of methylprednisolone divided into 12 weekly infusion. 3 grams, which is given as 500 mg weekly for 6 weeks. Then 250 mg for the next 6 weeks, that is 1.5. So 3 plus 1.5, that is 4.5 gram total dosage. Safety dose, single dose should not exceed 750 milligram unless it is a site-threatening dose where you can give a pulse of 1 gram in daily as over consecutive or even on alternate days. Cumulative is should not exceed more than 8 grams because we know that it can result in the various adverse events like the cardiovascular and hepatotoxicity. So when should we consider the second line agent? This should be considered when there is contraindication to steroids. Adverse effects outweigh the benefits. Then the failure of glucocorticoids, that also happens in many of the cases, like even 40 to 50% can have failure of the glucocorticoids. Then when there is a recurrent disease. So these are the situations where we can consider the second line agents. So what are the second line agent? The first one I would be going is a cyclosporin. It is an immunomodulatory agent. Inhibits the production of cytokine involved in the regulation of T cell activation, especially the transcription of interleukin 2. So it inhibits basically it inhibits a T cell proliferation. So we know that is also used in many of the like post-transplant patients also. So the mechanism of action as shown, you can see the cyclosporin blocks the interleukin 2 transcription, so which again results in the decreased proliferation of the T cells. So this one study, you can see here, it is dated to 1986, where cyclosporin and prednisolone versus prednisolone in the treatment of Graves' ophthalmopathy, a controlled randomized prospective study. 40 patients were enrolled, and you can see a cyclosporin was 5 to 7.5 milligram per kilogram body weight was given for 12 months. Steroids, you can see here, 50 mg per day for stage 3 and even for 100 milligram per day for stage 4 and 5 were given. But the steroids were given for only 10 weeks and it was withdrawn, while the cyclosporin was continued for 12 months. So, but you can see here the activity score before and after 10 weeks, you can see here in the group with the combined group of cyclosporin and prednisolone, there is a good reduction. Statistically significant reduction was shown. Even the you can see the Hartel's value of exophthalmometer measurements also show decrease the proptosis, and even a little bit better in the visual acuity, and was also shown with the combined treatment. And you can see the staging also, you can see the various stages also. In the combined group, the staging was also reduction was shown with the combined cyclosporin and prednisolone. So the 60% of the non-responders to single drug, that is those who were not respond to cyclosporin or prednisolone, when they were put on to combined treatment, 60% responded to the combined therapy. So you can see here, 60% responded, and you can see the total eye score, subjective eye score, proptosis, visual acuity was also better at 12 weeks and even at 24 weeks. So that was a major study that I could gather on the cyclosporin for Graves' orbitopathy. Then the second very important agent is a mycophenolate, a prodrug of mycophenolic acid, inhibits the inosine 5-monophosphate dehydrogenase inhibitor, and hence it results in the depletion of the guanosine nucleotide, and the T cell and B cell preferentially will be affected and inhibits their proliferation, and also the recruitment of macrophage and monocytes also will be reduced. Mycophenolate mofetil is not nephrotoxic. It does not increase the BP or alter the lipids, or it does not induce a fibrosis by TGF-beta. So these are the advantages. Then the very important trial published in the Lancet, that is a Mingo trial, where it was a randomized center trial, multi-center trial with Germany and Italy were the main major countries. 164 patients were enrolled, 81 into the methylpred and 83 into the methylpred and mycophenolate group. So you can see here mycophenolate sodium was used, and the dose was you can see here twice weekly 360 mg per day mycophenolate sodium. It was given for 24 weeks. You can see here the gray, light pink color is the one that is the improvement. So you can see the second column bar diagram will be the combined group of methylpred plus mycophenolate. You can see here that is the first and the second. The lighter color will be improving. So there is a definite change or improvement in the proportion of patients in all the at week 12, week 24, and even at week 36. And you can see here the forest plot also showing the combined methylpred plus mycophenolate showing the benefit. Even though statistical significance was not reached, it was showing the benefit in the activity. So, but the conclusion was no significant difference in the rate of response at 12 weeks or rate of relapse at 24 and 36 weeks. Well, the post-hoc analysis showed improved rate of response to therapy by 24 weeks in patients with active and moderate to severe Graves' orbitopathy. So that you can see here, post-hoc analysis showed benefit at 24 weeks. Then another Chinese study also you can see here, 80 were enrolled into the mycophenolate mofetil group and 78 into the glucocorticoid. You can see here the overall response was better with the mycophenolate mofetil group compared to the glucocorticoid alone group. Disease reactivation was also almost nil, and effectiveness was also better with the MMF. So compared to the glucocorticoid treatment, MMF is more effective and safer for patients with active, moderate to severe orbitopathy. Dose is 360 mg twice a day for mycophenolate sodium, and if it is mycophenolate mofetil, it is 1 gram twice a day for 24 weeks. You should monitor the CBC or the complete blood count and also the LFT. Then the next agent, anti-proliferative agent, azathioprine, mode of action similar to MMF, but it is not much effective as monotherapy. So there was one trial, that is a SIRTET trial, where prednisolone, then azathioprine and radiotherapy was given together as combined. Azathioprine, you can see 100 to 200 mg based on the weight. It was given for 48 weeks. And the odds adjusted ratio for the improvement in the binary clinical outcome was better with azathioprine analysis compared to the radiotherapy. And the conclusion was, the patient receiving oral prednisolone for 24 weeks, radiotherapy did not have added benefit. No added benefit for addition of azathioprine in the primary analysis, but the drawback in the study was there was large number of dropouts in the study. And the post-hoc analysis showed improved clinical outcome at 48 weeks with azathioprine treatment. And another major benefit was a reduction in the relapse rate after the steroid withdrawal. Next important, methotrexate, yes, inhibits the dihydrofolate reductase enzyme, results in T-cell apoptosis. And you can see one study I got it whether it works as a steroid sparing agent. You can see here 33 patients enrolled into the methylpred group and 39 into the combined group. And you can see here other activity and spin apoptosis, not much benefit. Only thing was the worsening of the visual acuity was lower with the combined group of methotrexate plus steroid compared to the steroid group alone. Concerns with the methotrexate, nausea, vomiting, liver dysfunction, very important, mucositis, anemia, and even sometimes thrombocytopenia. So how about these agents? Are all these agents discussed? Are they approved by FDA? No, none of these agents are approved by FDA so far. So next we move on to the biologic agents. So the first biologic agent and the first drug to be approved for the treatment of tau was the teprotumumab. That is, teprotumumab was the first agent approved by FDA for tau. What is this teprotumumab? It is an IGF-1 receptor blocker and a fully human monoclonal antibody of IgG1 subclass. Complete shutdown of the signaling of the IGF-1 receptor is what happens. OPTIC trial, very important. USA and Europe sites were enrolled with a more acute moderate to severe thyroid eye disease was enrolled with a CAS of 4/7. 41 in the teprotumumab group and 42 in the placebo group. And the dose was 10 milligram per kilogram body weight for the first infusion, followed by 20 milligram per kilogram for subsequent infusion, once in every 3 weeks for 21 weeks. So once in every 3 weeks for 21 weeks. Results, you can see a very good or a drastic response. You can see the proptosis response was better, or even best we could say, with the statistical significance. Change from baseline the proptosis, nearly 3 millimeter reduction in the proptosis. Clinical activity score reduction, very good. Overall response also very good. Diplopia response, change in base from the baseline, the overall scoring also very good or excellent with the teprotumumab. You can see here the second picture, the clinical photograph. First one is a placebo group. The second one is a teprotumumab group, and you can see on the right side the reduction in the eye severities and also the symptoms. And even in the MRI also showing the response with the muscle thickening reduction also. Safety aspect, yes, one adverse event mainly was seen was the muscle spasms, apart from the various smaller ones like alopecia, fatigue, diarrhea, headaches, and even other uncommon side effects have also been shown. So the concerns major was of muscle spasm, hyperglycemia, hearing impairment, and probable exacerbation of the inflammatory bowel disease. Another important thing noted was the relapse rate at 72 weeks after cessation of teprotumumab was as high as 40%. So that is very important. Relapse rate, relapse after stopping the drug is very high. But very, very important aspect is, if we know that it's not available in India, but in the US, single 500 mg vial will cost you $14,900. So that is like coming to 11 lakhs. So a total of 8 dosing requirement will come to nearly 1 crore rupees if you convert it to Indian money. Rituximab, another chimeric monoclonal antibody targeting the CD20 B cell marker. Direct effect is antibody-dependent cell-mediated cytotoxicity and also complement-mediated cytotoxicity are the direct effect. Indirect effects, structural changes and apoptosis of the B cells. So the study you can see here, B cell targeted therapy with rituximab, double-blind randomized trial. 32 patients were enrolled either with methylpred or rituximab. The primary endpoint was assessed with the CAS and also secondary endpoint was severity assessment. So the rituximab group, the CAS reduction was, you can see here, was almost significantly better. And with the low dose versus high dose, low dose was performing better compared to the high dose in the CAS reduction. And the active and inactive also, the inactive number was better. So you can see here, even the Graves orbital, the quality of life, the appearance scale, and even the visual functioning scale also. And the TRAB reduction was very much better or best with the rituximab compared to the methylprednisolone alone. And then one more study where the rituximab was compared with the placebo. You can see here 1 gram each was given 2 weeks apart. And here, but when it was compared to the placebo, rituximab did not show much benefit over the placebo. So there was a, you can see a discrepancy when it compared with steroid and with compared to the placebo. Side effects, yes, mainly infusion reaction are the common ones that we can see, like the myalgias and the skin rashes, etc. So giving it infusion should be given very slowly. Then there are prospective studies coming up, like the rituximab for hyperthyroidism, that is single dose of 500 mg with 12 months of 80-day trial is on, that is called a rigid study. Then the very important agent tocilizumab, now everybody will be familiar with this name of tocilizumab after the COVID usage also. It is an interleukin-6 receptor monoclonal antibody. There is a double-blind randomized clinical trial available. 32 patients were enrolled with a moderate to severe steroid-resistant orbitopathy. The study center was Spain, and the tocilizumab dose was 8 milligram per kilogram body weight or placebo, given on 0, 4, 8, and 12 weeks. And the total observation duration was for 40 weeks. It was monitored. And you can see here the primary endpoint CAS reduction was good, or the hyperemia and chemosis was statistically significant reduction with the tocilizumab even at 16 weeks. And you can see here the secondary endpoint reduction, that is a severity reduction, the diplopia score, the proptosis reduction and all was compared to the placebo at a 16-week, it was better with the tocilizumab group. So again, a very prospective molecule. But we have to monitor the lipid profile, LFT, complete blood count, and also we'll have to look in for the demyelinating disorders. And the next comparison, whether will biological agents supplant the steroids as a first-line treatment for the orbitopathy management. IV steroids, yes, proof of principle study more effective than placebo. That is a rituximab, not different from placebo. Tocilizumab more effective than placebo. Teprotumumab definitely more effective than a placebo. But other short-term, long-term side effects with the newer biologics, we have to wait and see. And the comparison with IV glucocorticoid, only rituximab study is available. Then other prospective agents, TNF-alpha inhibitor, etanercept, 10 patients, one study is there, where CAS reduction by 60% was noted, and ophthalmopathy index reduction by 24% was documented. And so again, another prospective medication. Pipeline drugs, yes, belimumab, fully human recombinant monoclonal antibody, which can target the B cells. Then bimatoprost, an ocular hypotensive agent usually used in glaucoma, is also being looked upon. And the supplementary treatment, there are supports some studies like the statins, whether it is an anti-inflammatory effect of the statin or the lipid lowering effect that is bringing the effect, that is yet to be known. But there are some reports of statins and the ACE inhibitors like enalapril and pendoxypyline also being used. Pendoxypyline can decrease the inflammatory markers like IL-1, IL-6, and IL-8, etc. So these are all some of the supplementary agents. So the take-home message would be tau, yes, it's still an area where more research is required in the pathogenesis and treatment. Those more research is warranted. Immunosuppressants can be a good add-on, especially mycophenolate can be a good add-on in steroid, partial or non-responsive tau. Biologics, especially teprotumumab, are showing promising outcome in this management. And teprotumumab is the only FDA-approved drug for TAVO. So thank you all for your patient listening, and the forum is open for comments and discussion.
Thank you for an excellent presentation. Would like to invite any questions from the esteemed faculty or from any of the delegates, if any. So I would start by asking one question with regards to the biologics as well as in non-responsive, in steroid non-responsive, we are quite aware of the huge cost associated with the IGF-1 receptor antibody, which is practically not feasible.
Yes, sir.
So which would you suggest with regards to next line treatment?
So from the available agents, definitely, I think mycophenolate is the one that is one showing the very good response. So we have seen that even with the combined steroid plus mycophenolate, very good response has been shown. So with the available agent, definitely we should choose a mycophenolate mofetil will be the good option rather than the cyclosporine, azathioprine, or even the methotrexate.
And with regards to rituximab, the data is somewhat,
yes, it's like a discrepant data is there. Like when it was compared with steroids, it was showing a benefit, but when it was compared with a placebo, not much benefit was shown. So again, we need a much more data on the rituximab in Graves' orbitopathy to have a concrete take to take it forward.
There is one question from Dr. Sujoy Ghosh. After methylprednisolone failure, what would be your suggested treatment? Mycophenolate, teprotumumab, given the fact that the OPTIC trial was in treatment-naive patients.
So yes, but even the data with the teprotumumab, which such a robust data and such a wonderful reduction in the activity and severity and all. So if definitely it is available, so I would suggest to go for a teprotumumab. If in the available setting, I would put it, but I was already told the cost, even the US, it is very costly. So if not, then the mycophenolate would be the choice.
And with regards to dysthyroid optic neuropathy, which is an emergency situation, unfortunately, we do not have much agents, and even rituximab is not that good after methylprednisolone, which is also itself not very effective.
Exactly.
Your take on that? I mean, other than surgical options.
Then only thing is for site threatening, it is only steroids are the one so far that is available. Maybe we can try with the steroids, and along with the MMF, if possible, we can be added upon. So if not, then the surgery will be, surgical decompression will be the only option left behind, sir.
In one of your slides, you suggested methotrexate improving visual acuity. Is it effective in dysthyroid optic neuropathy?
Oh no, sir, no data on that aspect. Only severe threatening eye disease it was shown, but even the combined aspect, only the not much. I mean, good reduction in the CAS and other proptosis was not shown. Only the thing that was shown was a visual acuity worsening was reduced when it was combined with the methotrexate and steroid was combined together.
Thank you. Yes, sir, please.
Yes, I think nothing much. When you think that all the patients are not responding to this prednisolone therapy, the one thing we'll have to pay in our country, taking into consideration the biological agents are not available and also very costly, and we don't know the long-term side effects. We must consider radiotherapy and surgery. And I think in my experience in the last 40 years, some of the cases which many of them have responded to steroids with prednisolone, but adding radiotherapy by selected cases gives very good response. And we are happy that no other side effects like giving biological agents in the long run. So that must be in a country like us, India, you must coordinate with your radiotherapist, and if he is very happy to handle the case with your not responding to steroid or surgery. These two things also has to be given a good place in our city. With the available, even the FDA has approved only one drug biological agent. So many things are there. So we'll have to wait and see what happens.
Thank you, sir, for the very valuable opinion. And thank you, Dr. Prem Narayanan, for an excellent talk. And I would like to hand over for further, to continue the other sessions to the organizers. Thank you.
Thank you. Thank you, sir. And thank you all the organizers.
Thank you, Professor Debmalya Sanyal, sir, and thank you, Dr. Prem Narayanan, sir, for that exciting and wonderful session. We now move on to the next session. For the next talk, I invite Professor R.V. Jayakumar, sir, who is the Senior Endocrinologist at Aster Medcity, Kochi, to chair the session. I would invite Professor Sujoy Ghosh, sir, Professor of Endocrinology at the IPGME&R, Kolkata, to deliver the talk.
Okay.
Over to Professor R.V. Jayakumar, sir, to conduct the session.
Thank you, Dr. Ajay. At the outset, let me thank the organizers of West Bengal Endocrine Society for inviting me to this August function. And the topics, the speaker is, I am very happy to chair a session which is going to be delivered by Sujoy Ghosh, the outstanding person, the professor of endocrinology at IPGME&R at Kolkata. And the topic is also very interesting because, as you know, thyroid cancer management, classification, management, categorization, area of controversy. And when I was a medical student or even a DM student 40 years ago, we are very happy because there are only CA thyroid means it always follicular thyroid cancer or papillary thyroid cancer. That is all. But as time goes by, so much of advancement has developed. They have started looking at each histopathological and the pathological diagnosis and immunopathological diagnosis have changed a lot. And now we have got very minimal thyroid cancer. So always controversy whether you are over-diagnosing, you are under-diagnosing, or you are over-treating. I think all this controversial area, we have got Dr. Sujoy Ghosh, who is going to give us a clear-cut view so that at the end of the day, we will be able to make up our mind when you get a case, how to manage. Dr. Sujoy, please.
Thank you, respected Jayakumar, sir, for your kind introduction. And I do understand that this webinar is probably being attended mostly by primary physicians and specialists, and probably very few endocrinologists. But this topic is an extremely hardcore endocrinology topic. And I have been asked to speak on non-invasive follicular thyroid neoplasm with papillary-like nuclear features, a very big name to it, an entity which I will refer to and as what the world now refers to as NIFT-P. Now, if you look at the pathological classification of thyroid tumors, Jayakumar sir was telling us that, you know, in the past people were happy by dividing tumors into benign and malignant, and anything that was malignant was differentiated thyroid cancer, and you kept on thinking that papillary thyroid CA and follicular thyroid CA and maybe medullary thyroid CA was all that you had. And it's been a journey of almost 70 years from what started in the 1950s, that when people looked at histopathology slides and looked at growth patterns. So they would look at a slide and say, this is someone who's got a follicular pattern tumor, or this is someone who's got a papillary pattern tumor. And that's how tumors were classified. Now, in the early 1980s and the end of 1970s, people realized that you've got to look at the nuclear pattern as well. So that's when people started thinking, you know, this is a papillary variant of follicular carcinoma. Thereafter, people realized that tumors could be encapsulated or they could be without an encapsulation. So encapsulated variants of follicular tumors came about. And then if there was invasion of such encapsulated tumors, it became malignant. And over a period of time, we realized that similar looking tumors, or maybe histopathologically, might behave very differently when it comes to the biology of the tumor in terms of it being benign or malignant. And all of this, that is this invasion, the biological behavior, the background driver mutation, might all decide how these tumors behave over a long term, or long-term outcomes could be different. Some of them might be needed to be treated aggressively, whether others might be behaving more like benign tumors. And gradually we realized that these tumors, whether benign or malignant, have certain driver mutations which actually cause the tumors to happen in the first place. And of course, there could be molecular markers on the basis of which tumors could be classified. So this is the kind of journey of, or the timeline of well-differentiated thyroid carcinoma. Like I said, in the 1950s, you had classification by architecture. That's, you looked at the pattern. Thereafter, you realized that, you've got to look at nuclear features. And then you can see that Chen and Rosai defined the follicular variant of PTC in the end 1970s. And then between the 1980s to 2000, you had various other definitions of borderline tumors, including the well-differentiated thyroid tumor with undetermined malignant potential. And then in the early 2000s, you came to look at certain molecular markers. For example, you realize that papillary thyroid cancer is predominantly a BRAF-driven tumor, whereas the follicular tumors are predominantly RAS-driven tumor. And then it's only in 2016 that we came up with the entity of NIFT-P. And therefore, not surprisingly, if you look at the total number of tumors of the thyroid that got classified, what Dr. Jayakumar sir was talking about, up to say 1980s, we thought most of the tumors were follicular tumors and lesser were papillary tumors because you were just looking at growth patterns. If you look at panel 1B, you then realized that along with the pattern of the growth, you needed to look at the characteristic of the nuclei to decide whether it was a papillary tumor or whether it was a follicular tumor. And if you look at panel 1C, you then realized that encapsulation was important, whether it's follicular predominant, it's important, and whether there is some kind of invasion of the follicular capsules is also important. And finally, in panel 1D, you've realized that these tumors, along with whatever you find on the histopathology, their molecular background is important, that all the papillary ones are BRAF-driven and the follicular ones are RAS-driven. And this is the seminal publication by Yuri Nikiforov and his team, when they kind of looked at and said, let us have a look at only those tumors which are encapsulated follicular variant of papillary thyroid tumors. Now, until that point of time, all encapsulated follicular variant of papillary tumors were thought to be overtly malignant and therefore termed encapsulated follicular variant of papillary thyroid carcinoma. And in this particular study, if you look at, what they tried to look at was, if you look at all the encapsulated follicular variant of papillary carcinoma thyroid, is it a homogeneous group of people, or is there some of these tumors which might behave as non-malignant tumors? So what essentially they did was, they looked at a retrospective cohort of individuals who had already undergone treatment. These were people who had encapsulated variant of papillary tumors, and they divided them into two groups. One group where these tumors, the capsule was intact, that is, they were non-invasive, and the second group where the capsule had been penetrated, and these were invasive variant of encapsulated follicular variant of papillary thyroid tumors. And all of these slides were looked at by various experts so that there was conclusion about the subclassification of these two separate groups that we are talking about. And all of these patients, if you see, had undergone predominantly either lobectomy or total thyroidectomy, but had not received any other form of adjuvant therapy. And if you look at the non-invasive encapsulated follicular variant of papillary thyroid tumors, and if you look at the 13-year follow-up that these patients had, none of them had recurrence of their thyroid tumor or so-called malignancy. So you can clearly see that between group 1 and group 2, there is a big difference in terms of long-term outcome, which essentially told Nikiforov and his group that in individuals who have a non-invasive encapsulated follicular variant of papillary thyroid tumors, these were probably not behaving like cancers, and these were not recurring, and these were tumors who were relatively indolent, relatively benign, and they did not need any therapy beyond a simple surgery like lobectomy. So they came up with this consensus to rename that non-invasive group of encapsulated papillary thyroid tumor variant as NIFTP. And they made these criteria. First of all was that there has to be a clear-cut encapsulation and demarcation. Point number 2 got modified later on. I'll tell you why. And they talked about nuclear score because you had to ensure that these were papillary variant of follicular tumors. There could be no vascular or capsular invasion, no tumor necrosis, and no mitotic activity. I'm not going to bore you with the scoring system of the nuclear scoring system, but it's enough to suggest that you had to have these criteria to suggest that these were indeed papillary variant of follicular tumors. So this is what they envisioned at that point of time, that these are clonal processes. These are tumors which are driven predominantly by RAS mutation. The overall pattern was follicular pattern. The nuclear feature was that of papillary lesion. And as you can see, their recurrence was very, very low. And they came up with this nomenclature of this new terminology, calling it non-invasive follicular thyroid neoplasm with papillary nuclear features. So as you can see, the word carcinoma is not present in the term NIFT-P. So they also looked at various molecular testing and NIFT-P. This is Nikiforov's paper, which again shows that it is predominantly a RAS-driven tumor. PPAR gamma fusion gene THADA BRAF. Note here it's 601E and not 600, and TERT were also present. So it's predominantly a RAS-driven mutation that's driving this group of tumors, NRAS being more common than HRAS, being more common than KRAS. The others, particularly the BRAF, V600E, the TERT, the RET, which are all features or driver mutations for papillary thyroid cancer, are conspicuously absent. However, there is no one single mutation which you could say, if you have this mutation, this is going to lead to NIFTP. And this is again that study trying to show that all of these various kinds of mutation, and if you can see in the column here, this is where we've talked about it's predominantly RAS driven. But that initial criteria of diagnosis of NIFT-P went wrong. And why is that? After the publication of that particular study, several people and researchers started publishing their own data of retrospective data. They went back to their slides and their blogs, and they came up and tried to show what was the long-term outcome in their so-called diagnosed cases of NIFT-P. I have highlighted the 2 studies at the bottom, and if you look at here, unlike the first 3 studies which show that there is no adverse outcome, the ones at the bottom show that there is adverse outcome. And if you see here that some of their tumors were BRAF 600E driven tumors. So essentially, these pathologists were doing something wrong. They were misdiagnosing few patients who had otherwise other diagnosis as NIFT-P. And this has been a problem of diagnosis of NIFT-P because histopathologically, you have to be very, very sure that you are correctly diagnosing NIFT-P. So Nikiforov's group made one comment that particularly for NIFT-P, you should probably avoid retrospective diagnosis. Because say, for example, you're looking at a slide that you preserved 10 years ago and you don't have the block. And for example, you're trying to look at, say, capsular invasion. Obviously, the plane in which you have cut the slide might make a difference. And had you cut the block in a different plane, you might have found that the capsule is penetrated and there is vascular or capsular invasion. So avoid making retrospective diagnosis of NIFP. So if you're trying to make a diagnosis of NIFP, the previous criteria said less than 1% papilla. It was now realized that you cannot have any papilla if you're diagnosing NIFP. Secondly, you cannot have any invasion. And to make that comment very, very confidently, you will have to cut the block in various sections, because in one section, there might be no invasion. In another section, there might be invasion. The third thing is molecular techniques are going to be useful for diagnosis of NIFP, because you realized that if you have a BRAF V600E, it is probably a papillary thyroid cancer that you're dealing with and not NIFP, and that these tumors are RAS driven. So the revised criteria, if you look here, it has now said no well-formed papilla, no Samoma body. So those are all exclusion criteria for papillary thyroid CA. And in addition, they have added secondary criteria for diagnosis. Now, I believe in the near future, this secondary criteria will become mandatory criteria in terms of the molecular criteria for diagnosis of NIFP, because we have to be very careful that we are not misdiagnosing certain histopathological disorders wrongly as NIFP. And therefore, it's not surprising if you look at all of these studies, you can see very high inter-observer variability of diagnosis of NIFP. What one histopathologist was saying NIFP, the other person was saying that it was something else, or the third person was disagreeing and saying something else. That's predominantly because it needs a very good histopathologist to correctly diagnose NIFP because of all of those strict criteria that I have stated. Number one, awareness by the histopathologist is important. Following strict diagnostic criteria by the histopathologist is important. And still then, there might be misdiagnosis of NIFP. So this is the algorithm that is to be followed by histopathologist for diagnosis of NIFP. So if he's first looking at a histopathology slide and looks at a tumor and asks himself, is this encapsulated or well demarcated? If it isn't so, then it cannot be NIFP. It's probably an infiltrative follicular variant papillary thyroid CA. So straight away it's out. The second thing, when you see that it's encapsulated, look at the capsule at various planes to see whether there is any capsular or vascular invasion. Because if there is invasion, it becomes an invasive variant of encapsulated follicular variant of papillary thyroid CA, as you could see the second group of Nikiforov study. So that's not NIFP. The third thing that you then look at, do you have any features like papilla formation or Samoma body, which are features of papillary thyroid CA? If that's the case, then this is probably micro papillary thyroid cancer, which is localized. And then if you see, is there any predominantly follicular pattern? If it isn't so, then it's again classical papillary thyroid CA. And then looking at the nuclear features to confirm that there are papillary variations of the nuclear features, only then will you be able to diagnose NIFP. So it's pretty difficult, and it has to be rigorous to make such a diagnosis. So if you look at worldwide, what is the incidence of NIFP? And what most studies would suggest that almost 1 in 6 to 1 in 5 of all papillary thyroid cancer proportion would be NIFP. So if you have, say, out of 150 odd cases, if you find that you've got 30 cases of papillary thyroid cancer in your cohort, you can expect 1/5 of that, means about 6 in 150 will be NIFP. So what was clubbed initially as papillary variant of thyroid cancer, you can see a big proportion of that is actually not cancer. And if you look at reported data, unfortunately, we still don't have any publication from India. Probably our paper, which we are writing up, is going to be the first paper. There's only 3 papers from Korea in the Asian series. And if you look at the Western world, there's a big difference in the incidence of NIFT-P. And that could reflect to some extent ethnic variations, and probably much more importantly, the training of the histopathologist and the awareness of the clinician. So what does NIFT-P mean to the clinician? To the clinician, it means that the chances of recurrence is near 0. And if you look at various studies, you can see that we should probably not be over-treating. And like even PAPCA, there's a female preponderance of NIFT-P, and that size of the tumor cannot be used to diagnose NIFT-P, because if you see the size in this particular study, it's anywhere between 0.7 centimeters to 9.5 centimeters. So the mere fact if a tumor is big, don't think it cannot be NIFT-P. And this is Nikiforoff's statement, which he stated that this is a group of people where treatment can be de-escalated because they are unlikely to benefit from completion thyroidectomy or radioiodine therapy. And if you look at the ATA guideline, which published this statement to say what happens to the guideline that had been published 2 years prior, do we need to make any differences to this particular subgroup of individual? We need to understand that this is a low-risk neoplasm, but we still cannot say that this is not cancer, and that at this point of time, lobectomy itself is good enough and judicious follow-up is what is recommended. And this is the 2015 guideline. It just that 2017 statement just reiterates what has been stated here, that this should be considered like a low-risk differentiated thyroid cancer, and radioiodine ablation is not recommended. What about our understanding of thyroid carcinogenesis? We have now realized that perhaps thyroid carcinogenesis is not a single-step process, but a multi-step process. So for example, in a papillary growth, the BRAF is the main driver mutation, which will first form a papillary microcarcinoma, and maybe in the next step, go to a classic PTC. In case of a follicular growth pattern, RAS is the predominant driver. You might have a NIFT-P, which might then become invasive encapsulated follicular variant of papillary CM. Now, the stage at which you have done the surgery and diagnosed NIFT-P, that stage is probably an intermediate between a benign lesion and a malignant one. And this is similar to the multi-step cancer development of follicular thyroid, of colonic carcinoma. So this is perhaps similar to that. But we still have several unanswered issues. For example, if you're doing an FNA, can you predict that this is going to be NIFT-P even before you've done the histopathology? The answer to that is probably no, and that most of the FNA reports of what finally becomes NIFT-P is in the intermediate category of 3 and 4. And if you look at the Bethesda system, once you've got a histological diagnosis and tried to figure out how good was my Bethesda, you will realize that with the introduction of NIFT-P, the risk of cancer categories of both particularly classes 3 and 4 has reduced, because this group is no longer treated as cancer, but treated as perhaps a tumor, which is somewhere in between benign and malignant. And there are certain cytological features, cytopathological features, which are suggested to be supportive of NIFT-P, but none of them are very conclusive. Similarly, in terms of ultrasonography, can you predict that this is going to turn out to be NIFT-P? You can perhaps predict that it's going to be invasive follicular variant of papillary thyroid carcinoma. But apart from saying that if it's circumscribed oval with a rim of very well circumscribed and mostly hypervascular, you really cannot predict from an ultrasound that this is going to turn out to be NIFT-P. So this particular statement by AACE actually asked more questions than answers. It asked 3 pertinent questions. So what's the tumor biology? Is this benign or is this malignant? Can we preoperatively diagnose NIFT-P, which I've already stated that we probably can't with certainty? And what about the diagnostic confusions in terms of histopathology? One histopathologist saying something and the other one refuting the same. Can we come to some kind of a conclusion for particular question 1 and question 3? So to address that, we could probably use molecular profiling in the diagnosis of NIFT-P. This is one of our publications that has already been published in this month's JCEM as the lead article. This has nothing to do with NIFT-P, but we tried to look at plasma cell-free DNA to differentiate malignant from benign tumors. And the key findings of our study was that cell-free DNA is able to differentiate malignant from benign nodules with a sensitivity of 100% and a specificity close to 90 to 93%, and that the quantum of rise of cell-free DNA correlated with the TNM staging, including telling us that whether there was invasion or spread, and there was post-operative normalization of cell-free DNA, and we were able to detect driver mutations in the cell-free DNA as well. The reason why I brought this up is because we wanted to use the same technique to try and figure out whether the so-called diagnosed NIFT-P in our cohort were indeed NIFT-Ps or not. And this is the accompanying editorial. I shall skip that for paucity of time. So if you look at our data of NIFT-P, we had to start with our own histopathologist of our institute saying that we had 12 patients of NIFT-P on the basis of the histopathological features that I've already discussed. And in them, we went for molecular profiling. We looked at their cell-free DNA levels, and we then looked at all of the driver mutations that we know are known to cause thyroid cancer, both in plasma as well as FNA material. And we also looked at expression of long non-coding RNA, which are associated with NIFT-P, and also the expression of level of microRNA associated with NIFT-P that's already there in literature. The long non-coding RNA data is sparse. Perhaps ours is probably going to be the first publication on that. And in terms of the histopathological diagnosis of NIFT-P, what we did was, once our in-house histopathologist said that this was NIFT-P, we sent it out to 2 external experts to have an independent look at the slide, as well as the block to tell us what the diagnosis was. And these are our 12 patients of NIFT-P. I'm sorry that this is such a busy slide. So I'll ask you to look at column by column. Number 1, you can see that these are all women, none of them are males. They're all in their 20s or their 30s. Their ultrasound TIDAD scores is mostly 3 to 4, and their FNA Bethesda score is usually 3 to 4, with only 1 being 5 and 1 being 1. The reason why I'm saying this is in concordance with what literature suggests. And you will find that in cases 1 to 8, all 3 histopathologists agreed that it was NIFT-P indeed. But in cases number 9, 10, 11, and 12, there was discordance between our in-house histopathologists with the external experts. And you can see case number 9 actually turned out to be papillary thyroid carcinoma. And cases 10, 11, and 12, there was invasion of the capsule at a different plane from the one that our histopathologist had seen. And so they were invasive encapsulated follicular variant of papillary thyroid cancer. Now, this is important to know because, we might have wrongly labeled case number 9, 10, 11, and 12 as NIFT-P. Now, was there any way that molecular techniques would have actually helped to pick up the mistake or the error that one histopathologist is making? And how do we know that the external expert is doing a better job? So if you look at the cell-free DNA concentration, the first 8 cases where all 3 histopathologists said that this was NIFT-P had values less than 67.9, telling us that biologically that these tumors were benign. similar to our study that's published in JCM. Whereas in case 9, 10, 11, and 12, the cell-free DNA levels are increased, clearly telling us that these are malignancies and probably not NIFT-P. So straight away telling us that our first histopathologist is probably incorrect. And if you then look at the driver mutations that we found from both the plasma as well as from the FNA material, in case number 9, you see that there is a BRAF V600, which we know is associated with papillary thyroid cancer. So the second and the third histopathologist who said that this is papillary thyroid cancer, this is actually a micropapillary thyroid cancer, which is localized, which is encapsulated, and therefore has a BRAF mutation and has a cell-free DNA level of 79.8, telling us that the molecular markers was supporting what the expert histopathologist was saying. And in case number 10, 11, and 12, we clearly see that these are RAS-driven mutation. So of course, they are follicular tumors. But if you look at the cell-free DNA level in them, they give us a signal that these are invasive follicular tumors where perhaps the capsule has been breached and therefore are malignancies. So here, the molecular profiling clearly telling us that it might have a role in being another criteria for diagnosis of NIFT-P. So we move on to the next bit, that those cases where we got things wrong. This is the one which is right, case 2, which is truly NIFT-P. In case 9, where there was micropapillae, as you can see here, turned out to be papillary thyroid cancer. That's the BRAF 600E mutation that was found. And this is case 10, as you can see, in a particular plane, there is capsular invasion that is present, telling us that this is no longer non-invasive encapsulated tumor. So we then moved on to look at long non-coding RNA and microRNA in our patients of NIFT-P. So we essentially looked at the PVT1, the hot air, the XIST, and the andril. And what we found is that the PVT1, the hot air, the XIST, and the andril are all upregulated in our patients with cancer. And if you look at the CAS-C2, they are all downregulated in the thyroid cancer. So clearly telling us that these could also play a supportive role in the diagnosis of NIFT-P or thyroid cancer in at least this subset of individuals. So the long coding RNA data might also be useful. Moving on from there, if you look at the microRNA data, there are some in red and some in blue. I'm not complicating things here, but these would also help us in differentiating malignancies from benign tumors. So if you are having a patient of NIFT-P as stated by one of your histopathologists, if you look at the cell-free DNA level, if you look at the driver mutations in the plasma, in the FNA material, or if you look at the long non-coding RNA or the microRNA, you will be able to pick up errors of diagnosis by a histopathologist because it's a difficult diagnosis to make. And again, like our own JCM paper, the cell-free DNA level was able to make the diagnosis correctly in 100% of our patients. So the key points, if we look at, this is the new classification of thyroid tumors. And you can see, apart from benign and malignant, you now have another group of encapsulated follicular tumor, which is called borderline tumors, and NIFT-P actually figures there. And if I have to finish with the key points, NIFT-P presents as thyroid nodules, whether as part of a solitary or as part of multifocal tumor. The diagnosis on FNA and ultrasound is difficult to predict that this is going to turn out to be NIFT-P. Most of them are going to have either a TIDATS 3, 4, or 5, and a Bethesda of 3, 4. Histopathological diagnosis is what is considered to be gold standard, but we understand there is high degree of inter-observer variation, and that pathologists will have to be trained up to make a correct diagnosis of NIFT-P. Identification is critical to avoid overtreatment, because if you are able to diagnose NIFT-P correctly, then apart from lobectomy, you're probably not going to do anything. The biological behavior of the tumor, we have perhaps from our cell-free DNA data can probably say that even if this is a multi-step tumor which is developing or is in the process of development, at least at the stage in which the surgery has been done and the diagnosis of NIFP has been made, the tumor in terms of the cell-free DNA is behaving like a benign tumor and not a malignant tumor. And therefore, not surprisingly, you don't have recurrence of that tumor. And these are RAS-driven tumors. And I'm certain that in future, molecular techniques will become mandatory criteria for diagnosis of NIFP. I shall stop there. Thank you very much.
Thank you, Dr. Sujoy Ghosh, for the excellent presentation. Only thing is, it is as you said correctly, it is mainly for hardcore endocrinologists. This much of a specialized talk is required. Anyway, what I understand is that at the end of the day, now all of us must have BRAF and the RAS, the mutation, molecular mutation studies is going to be a must to make a correct diagnosis, histopathological diagnosis of this condition. And if you can make the diagnosis of non-invasive follicular, your diagnosis of NIFTP, then you can be sure that the patient can be unnecessarily can be avoided of the unnecessary too much of treatment. That is why people are saying we are over-treating thyroid cancers. But we must make it sure to the public that we are not over-treating, because it is difficult. There are thyroid cancers are not cannot be all put in one basket. It is a different cup of tea. So each has to be given its own line of treatment. So any comments from the audience?
I just have one question, Sujoy.
Yes, sir.
Excellent presentation. I'm much wiser today. Do you think that this iodization program over these 2-3 decades could have changed the pathology, that earlier we were never seeing these kind of pathology, what we are noticing now, or probably we are more wiser as far as pathology is concerned?
I'm not very sure what impact of iodization has had on tumors of the thyroid in terms of whether it's made a difference or not, because I don't think we have data to make that comment. But like I was trying to talk about the evolution of histopathological diagnosis of thyroid tumors, I think we are wiser, because we initially looked at gross histopathology saying, oh, this looks like follicular pattern, so this is a follicular tumor. Oh, this looks like a papillary arrangement, so this is a papillary tumor. Then we realized, okay, hang on, we need to look at the nucleus as well, because the nuclear pattern probably defines what's going on. Thereafter, we realized, is this encapsulated or is this not encapsulated?
Right.
Then we realized, is the capsule invaded or is it not invaded? And then these molecular tests came up and said, okay, is the driver mutation, is this a BRAF V600E driven or is this a RAS driven? So I think all of that has made a big difference. And the bigger confusion has been people who were told that they had a cancer. Now you go back and look at their blocks and say that this is probably not cancer and we probably have overtreated. I think there's a problem in the nomenclature, and I think we need prospective long-term data, because all that we have of NIFP as of now is retrospective. And like I discussed, there's a big problem of retrospective data, because unless and until you have the tumor block with you available and you've actually gone and looked at it in different sections and slices, along with the molecular markers, you are never sure that it was actually NIFP. And I think Dr. Nalini has asked a question in the chat box here, is that you went and said somebody has a NIFP and you made a wrong diagnosis. Then you've actually messed things up, because you've told him that you don't need any further treatment, and then things go wrong. So that's why I believe that we have to be very careful when we are labeling someone as NIFP. Because we have to definitely be sure that there is no invasion, there is no papilla, and that it is a RAS-driven tumor.
So unless you do all the investigations, you really, with no surety, can say it is NIFP. Am I correct?
Correct.
All right.
But the current criteria still says, it's a secondary criteria, the molecular weights.
I think, Dr. Sujoy, there is in good old days, in 1970s, I have published the good old thing, the iodinization has got a effect on the type of tumor seen in a place. I have, in 1970s, in the Indian Endocrine Society, we have presented a paper because in South India, it is mainly because there is not much iodine deficiency at that time compared to North India. We mainly see more of papillary tumors, whereas in North India, where it is iodine deficiency, it is a follicular tumors. When we analyze the ordinary histopathological diagnosis from 2 centers in North and South in 1970s, we have presented a paper saying that iodine status of the community may affect whether it is a follicular tumor, CA is the most old, or papillary. But that all gone with the availability of newer FNACs. At that time, not much of FNACs are available. And nowadays, with the availability of molecular markers and all these histopathological changes, that are all gone. So iodine effect and the type of tumor and all. And the second thing is now universal iodinization. So we can't categorize places as iodine deficiency and also. Anyway, markers, okay, carry on, Dr. Mukherjee.
Can I ask one question to Sujoy?
Yes, sir.
Sujoy, see, I'm coming from a clinical point of view. I'm a hardcore clinician. See, generally, if you have a thyroid nodule, FNAC suggests it could be malignancy. What happens? The surgeon goes in, does a lobectomy, and in better centers, probably they'll do a frozen section. And if they think there is malignancy, they will do total thyroidectomy and central lymph node clearance. That's one way of dealing with it. And some centers, as you presented Nikephorov's data, some people will do a hemithyroidectomy, wait for 5 to 7 days, and then go and do completion thyroidectomy. So your diagnosis of NIFT-P, if you're doing a frozen section, you can't get a diagnosis of NIFT-P. You'll probably get a follicular variant of papillary thyroid cancer. So you could end up with total thyroidectomy anyway. And then you will find that it's low risk. So you will not go for radioactive iodine ablation therapy. So isn't NIFT-P more of a academic discussion, or do you think it will change management? I think it will only change management if people are doing hemi first. Maybe in that situation, probably it might change management, where they will not go ahead and do a second stage total thyroidectomy. Your comments.
Right. Okay.
I think we are running short. I think please be brief.
Quickly finish, sir. Most of these patients will come up with an indeterminate nodule. That's how they will present. And under current circumstances, most of the surgeons would go for a lobectomy. And once you've got the report back that this is NIFT-P, you're not going to go for further treatment.
I think we are running short of time, and I think the next speaker may be eagerly waiting. So I may thank Dr. Sujoy Ghosh for the excellent presentation and for the participants for active participation. And I hand over and thanks for inviting me to chair this session. And I hand over the mic to the organizers.
Thank you, sir.
Thank you, Professor Jayakumar, sir, and Professor Sujoy Ghosh, sir, for that excellent session. We now move on to the next talk. I would like to invite Dr. J.J. Mukherjee, sir, Senior Consultant in Medicine, Diabetes and Endocrinology at Apollo Gleneagles Hospital, Kolkata, to chair the session. I invite Major General Dr. Raman K. Marwa, sir, who is the Scientific Advisor and Senior Consultant Endocrinologist, International Life Sciences Institute and Consultant Projects, Department of Endocrinology, AIMS, Ministry of Ayush, to deliver the talk. Over to J.J. Mukherjee, sir, to conduct the session.
Thank you. Thank Endocrine Society of Bengal for giving me this opportunity, and thank you for asking me to chair a session which is more clinically driven. We have had two very high-powered talks, one on thyroid-associated orbitopathy, and next we just had a very fantastic discourse by Sujoy on a newer variety of thyroid carcinoma, thyroid tumor. With that, we're coming to a more clinical topic, and I think a topic which all our friends who are listening at the moment can relate themselves to, and that is thyroid function in pregnancy. And this is such an emotive topic, you see. I mean, I'm sure Dr. Marwa will be taking us through it. There are dearth of randomized controlled trial data. There's a lot of debate and discussion as to what are the cutoffs. There's a lot of debate and discussion and doubt as to whom to treat, whom not to treat. And if you just search for guidelines on thyroid function in pregnancy, just go and search, and in the last 10 years, you will find at least 4 or 5 guidelines. So the more the number of guidelines, that tells you that we don't know enough or don't know well as to what to do. That's why we need somebody who's senior, who can really, you know, need the literature and come up and give you some real straightforward answers, take-home points as to how to interpret thyroid function tests in pregnancy. With those few lines, Dr. Marva, I hand over the stage to you. Please go ahead.
Thank you, Dr. Mukherjee, for those kind words. And thank you, Endocrine Society of Bengal, for inviting me. I will try and keep this very simple because I believe most of them are practitioners who are listening to this. And I hope I will go through very generalized, simply, how do we interpret what is the significance of correct interpretation of these thyroid function tests in pregnancy. So you all know that thyroid disorders are very common in women of childbearing age. And since the demand for the hypothalamic pituitary thyroid axis is increased during pregnancy, the thyroid dysfunctions, particularly in those with borderline thyroid abnormalities.
Dr. Marva, may I interrupt? Are you showing the slides? Have you shared your slides?
Oh, just a minute.
Yeah, please.
Now, how do I go back?
No, you just go to the screen below. There's a green thing called share screen.
No, I know that, but okay. I have kind of, I really don't know because I've
Sir, just minimize the PowerPoint screen, sir. Just minimize it.
Not getting minimized. That's the.
Just exit the presentation view, sir.
Yeah. Could you do that?
Sir, you just exit. Press escape, sir. Press escape. It will take you out of the presenter view.
Right. Okay.
Now you can minimize it, sir.
All right.
And now just share the screen.
Yeah. All right. Yeah. Is that all right?
Yes,
much better.
Yes, sir. Yes.
All right. Okay. So as I was saying, that since the demand of hypothalamic pituitary axis is increased during pregnancy, thyroid dysfunctions, particularly in those with borderline thyroid abnormalities, are very frequently encountered. And we know that maternal thyroid functions are important, especially in the first half of pregnancy where the fetal thyroid is developing. And therefore, correction of both overt hypo and hypothyroidism dramatically reduces the risk of adverse outcomes like fetal loss and preterm births. However, benefits of treating marginal thyroid dysfunction such as subclinical hypothyroidism or isolated hypothyroidism are less clear. So as I said, why this is important is because there are a lot of complications that one comes across if you develop hypothyroidism in pregnancy. As this chart very clearly shows you, not only maternal complications like anemia, preeclampsia, placental abnormalities, low birth weight infants, postpartum hemorrhage, myopathy, and in fetal, you have cognitive impairment, neurological abnormalities, developmental abnormalities, and congenital hypothyroidism. And in neonates, you may develop hyperbilirubinemia or respiratory distress. Similarly, there are several complications if you have hyperthyroidism in pregnancy. Well, the maternal complications may be miscarriage, pregnancy-induced hypertension, preterm labor, placental abruption, heart failure, or thyroid storm. As far as fetal and neonatal risk are concerned, you may have stillbirths, low birth weight, or IUGR. The fetus or the neonate may have goiter, hyperthyroidism, or hypothyroidism. So these are the complications that one can come across if you have any of the thyroid dysfunctions during pregnancy. So let me take you through what is the impact of pregnancy on thyroid functions. Well, during normal pregnancy, what we see is that the thyroid gland increases in size. It produces 50% more T4 and T3 and also requires 50% more iodine. But if you take the normal TSH range, that is compressed with a lower limit of normal at both ends of the spectrum. That means if the upper end is 4.2 in normal people, in pregnancy, it will get down to say about 3 or 3.5. So the TSH levels are compressed. And the physiological changes that occur in pregnancy, as you're all aware, there's increased estrogen, which leads to increased serum thyroid binding globulin, resulting in increased T4 and T3 levels. There is depletion of iodine in pregnancy because of increased iodine clearance and increased thyroid uptake. And that is the reason why we need higher thyroid iodine intake of about 250 micrograms per day instead of 100 to 150 as required by other people. HCG activity during first trimester is well known to have increased FT4 and suppressed TSH levels. And with increased concentration of the enzyme called deiodinase 3 in the placenta, which increases T3, T4 degradation, and therefore it reduces the thyroxine transfer to the fetus. And that is the reason why we need higher replacement during pregnancy. If you see this graph, you'll know, just concentrate on TSH levels. The TSH levels are suppressed in the first trimesters and they gradually then get increased and come back to normal by the middle of second trimester. This is because there is a high level of HCG, human chorionic gonadotrophin, which is similar to and behaves like TSH. So once this level goes up, obviously the TSH level goes down. Similarly, if you take FT4, free T4, it increases during first trimester, as I mentioned, and gradually gets down to normal after mid-second trimester. The total TBG, you clearly see increasing and then finally getting into a plateau near the end of second trimester. And so this is what I said, that in the first trimester, TSH is low because of HCG levels being high and FT4 levels are high. Usually what doctors find it very, very difficult to diagnose both hypo as well as hyperthyroidism in pregnancy, probably because of common signs and symptoms of both these disorders during pregnancy. So in order to really know what are normal ranges of thyroid functions in pregnancy, what has been suggested is that you should form your own normal reference range for your population. In case you don't have your own reference ranges, you may take reference ranges of population of similar kind of population, say Asian population. In case that data is not available, then you should take 4 micro-international units per ml as the cutoff, upper level of THS as the cutoff. However, we did this study in 2008 in 541 women, where we had tried to take or exclude all these pregnant women who had anything which would have disturbed their thyroid function, say goiter or presence of antibody, or iodine intake was low, or there was a family history of thyroid. All these pregnant women were excluded from the study. But this is a slide which shows you all the studies which have given trimester-specific reference ranges. And when American Thyroid Association in 2011 made the guidelines, ours was one of the papers which was considered to make the guidelines for reference ranges of pregnancy in 3 trimesters. And what we showed in our study was that the TSH levels you will see increases from the first to the second and to the third. And whereas free T4 again is higher on the first trimester and decreases in the second and further decrease in the third. Whereas when we devise the 5th and the 95th percentile, you will see the upper level in the first trimester of TSH was 5, in the second it was 5.7, and again 5.7. So the upper 95th percentile, that is the upper range of TSH, was found to be 5, as far as mean is concerned, it ranged from 2.4 to 2.6. Recently, Dr. Rajesh Rajput had made trimester-specific reference intervals for thyroid hormones during pregnancy at a tertiary care hospital in Haryana in India. He did the same electrocumulation evaluation of TSH levels in the first, second, and third trimester, but he used 2.5th percentile and 97.5th percentile, and clearly showed that TSH level increased from the first trimester to the third trimester. But if you notice here, the upper range, 97th percentile, ranged from 3.7 to 4.64. And that is the reason why we recommend that for our Indian pregnant women, we should consider 4 as the upper limit to define what is subclinical hypothyroidism. He then also showed similarly that FT4 increases, is higher in the first trimester and decreases in the second trimester. And these are the normal means, and 25th, 5th percentile, and all these figures have been given. What are the recommendations from the other societies? Surprisingly, our Indian Thyroid Society guidelines said that in the first trimester, please consider 2.5 microinternational units per liter as the upper level. And in the second and the third trimester, consider 3 as the upper level limit. Similar to European Thyroid Association guidelines, our American thyroid guidelines very clearly say that you should use locally derived reference ranges from a specified pregnant population. And if that is not available, as I mentioned earlier, you should use locally derived reference ranges from a similar population from another country. If that be not available, then you should use upper TSH reference range of 4. And this is what the recent study from Haryana has shown, that in all the 3 trimesters, we should try and consider 4 as the upper limit. Surprisingly, FOXY also has given similar guidelines as Indian Thyroid Association and European Thyroid Association, that is to take 2.5 as the upper limit in the first and 3 in the second and the third trimester. The lower levels range from 0.1 in the first, 0.2 in the second, and 0.3 in the third, which is significantly lower than what both our Indian studies have shown. So this is one of the studies which shows you the high prevalence of hypothyroidism in pregnancy, which was an epidemiological study from 11 cities and from 9 centers, which clearly showed that if you take 4.5 as the cutoff, this was Dinesh Dhanwal's, who was the principal lead author, shows that in the first trimester, the prevalence of hypothyroid was 15%, 12% in the second, and 14% in the third trimester. But if you take 2.5 as the cutoff, which has been recommended by European Thyroid Association and our Indian Thyroid Society, the prevalence becomes very, very high, almost 3 times higher if you take 4 or 4.5 as the cutoff. Well, several studies with Dhanwal, Jaiswal, our own studies, Singh and Mandal have all shown high prevalence of subclinical hypothyroidism and overt hypothyroidism in pregnancy. And so what are the principal guidelines for management of this hypothyroidism during pregnancy? What it shows is that the thyroxine requirement increases approximately 30 to 50% during pregnancy. And therefore, the moment the doctor comes to know that a patient who's already having thyroid problem and is on supplement therapy, you should immediately increase the dose by 20 to 30% and then review every week till the TSH levels are in that trimester levels till they become euthyroid. This is the same slide showing that the demand increases by 30 to 50%. Now, do all women with established hypothyroidism prior to pregnancy on LT4 therapy require a dose increase? Not necessarily. It is only seen in 35 to 62% of women with autoimmune hypothyroidism that they need an increase of 20 to 30% in their supplement therapy. Whereas in athyroidic women, which may be a result of ablation for Graves or thyroidectomy for benign thyroid diseases or thyroid cancer, 70 to 100% of these pregnant women will need increase in the supplement therapy. So this is a slide, again, American Thyroid Association independently suggesting that you should increase the dose of LT4 by 20 to 30%. So when the prevalence is so high, should we undertake universal screening or we should undertake targeted screening in pregnancy for thyroid functions? So this is a meta-analysis of 10 eligible studies where 4 studies very clearly demonstrated that universal screening may lead to less miscarriages and pregnancy complications. 2 studies demonstrated that universal screening would be cost effective, but the other 4 studies did not suggest the same. Again, these 5 studies, when meta-analysis was done, it clearly showed that if you take case-based screening or targeted screening, you may miss up to 49% of pregnant women with thyroid dysfunctions. So that means it further supports for advocacy of universal screening methods for thyroid disorders in pregnancy. Then there was a survey carried out by 140 doctors of, conducted by American Thyroid Association, and 74% of these endocrinologists advocated for universal screening, 18% were against universal screening, and 8 were unsure. Well, Indian guidelines say that all pregnant females should be screened at first antenatal visit by measuring TSH levels. Well, American Thyroid Association says, well, there is insufficient evidence to recommend for or against universal screening for abnormal TSH concentrations pre-conception, except for those cases where women are planning assisted reproduction or they are known to have positive antibodies. Now, so there is not sufficient evidence to undertake universal screening. So which are the patients who are either seeking pregnancy or who have just become pregnant or newly pregnant? Who are these who should undergo evaluation of thyroid functions? Well, only those who have the following risk factors, as is shown in this slide, that if a pregnant woman has a history of hypo or hyperthyroidism, or known to have thyroid antibody positivity or presence of goiter, or has had head or neck radiation, or she's more than 30 years, has type 1 diabetes or any other autoimmune disorder, or there is a history of pregnancy loss, preterm delivery, or infertility, or there is a history of multiple prior pregnancies, or there is a family history of autoimmune thyroid diseases or thyroid dysfunction, or morbid obesity, or one is taking drugs like amiodarone or lithium, or recently have been given iodinated radiograph contrast, or residing in area which is known to moderate to severe iodine deficiency. So these are the conditions a clinician should be aware of, that these are the ones who are at the risk of thyroid dysfunction during pregnancy. And they should have their thyroid functions before they plan to conceive or during early pregnancy. So how do you manage hypothyroidism? So if a pregnant woman has thyroid antibody positive and the TSH level is more than 2.5 microinternational units per liter per ml, the advice, what is recommended is that you treat these patients, because 2.5 is the upper limit taken by American Thyroid Association in the first trimester. If antibody is negative, but TSH levels are more than 10, again, it is recommended that you treat these pregnant women. If antibody is negative, but the TS level is between 4 and 10, well, you may consider, depending on your clinical acumen, whether you should treat or not to treat. But you must consider treatment in this patient. If it is TPO negative and your TSH is between 2.5 and 4, there is no recommendation for these patients to be treated. And also to add on here, if there is isolated T4 levels which are low, or what is called isolated hypothyroxanemia, there is no recommendation for treatment during pregnancy. So what about hyperthyroidism in pregnancy? I've already told you the complications earlier. Now, overt hyperthyroidism complicates only 0.05 to 0.2% of pregnancies. Graves is the most common of the lot. Subclinical hyperthyroidism has a prevalence of around 1.7%. It is also often associated with increased SCG levels during early pregnancy, and hyperemesis gravidarum seems to be associated with subclinical hyperthyroidism. So what happens? What is the effect of pregnancy on the Graves' disease? The symptoms get aggravated in the first trimester because of increase in the HCG production, whereas in the second and the third trimester, the clinical thyrotoxicosis improves. That is because there is reduction of TSH receptor stimulating antibody levels during pregnancy, which improves the symptoms of Graves' disease. However, post-pregnancy symptoms increase again due to sudden rise in the level of TSH receptor stimulating antibodies. So in the first trimester and in postpartum, you have aggravated symptoms, whereas in the second and the third trimester, the clinical symptoms become much less. So just to give you an idea, if there is a case, 30-year-old, 12th week of pregnancy, complains of vomiting more than 15 times, epigastric pain, nausea, dizziness, lethargy, no symptoms suggestive of hyperthyroidism as such, no history of hyperemesis gravidarum in her first pregnancy. There is no history of medical illness and family history of thyroid disease. Patient is afebrile, pulse is 108, BP 100/60, no tremors, no icterus, elevated bilirubin or ALT or AST. FT4 is mildly raised, TSH is 0.09, TSH receptor antibody or anti-TG or anti-TPO antibody were negative. Hepatitis ABC was non-reactive. What was the diagnosis? This is a very, very clear case, as you know, of hyperemesis gravidarum, which leads to, with the increased T4 levels and low TSH levels. And this is a transient phase, and they only need IV dextrosaline with potassium chloride. They don't need any anti-thyroid drugs. And the TFT normalized by 13th week in this, and vomiting was significantly reduced. So this was a case of hyperemesis gravidarum with gestational transient hyperthyroidism, where we don't need anti-thyroid drugs. It will subside by 18th week anyway. All these cases subside by 18th week. Your TSH comes back to normal, T4 comes back to normal. So what are the principles of management? I first now mentioned that for hyperemesis gravidarum and gestational hyperthyroidism, anti-thyroid drugs are not recommended, as no benefit was seen in the reported case studies. You just have to give supportive therapy with antiemetics, hydration, and electrolyte replacement. The transient free T4 levels normalize by itself without any anti-thyroid treatment. And anti-thyroid treatment should be started only if their hyperthyroid symptoms or signs are persisting and remain abnormal even after 18 to 20 weeks of pregnancy. So if the thyroid functions do not normalize and the patient still has symptoms and signs of hypothyroidism, then you should think of treating such pregnancies with anti-thyroid drugs. Another thing one should remember is that subnormal TSH, hyperthyroidism, must be distinguished from both physiological changes during pregnancy and hyperemesis gravidarum, where I told you that there is a slight increase in FT4 and TSH is slightly depressed, but there is no signs and symptoms obvious of hyperthyroidism. So therefore, you should not treat them with anti-thyroid drugs. Diagnosis of Graves' disease is supported only if there is evidence of diffuse goiter, autoimmunity with presence of anti-TSH receptor antibody or thyroid stimulating hemoglobin, or if there is a family history of thyroid disease in these cases, or the ratio of T3, T4 is more than 20, then you should think of a Graves' disease. So for overt hypothyroidism during pregnancy, thiazide are the treatment of choice. You start treatment immediately with propylthiouracil. In case of allergy or intolerance, carbimazole or methimazole can be substituted. So FDA's review found that congenital malformations were reported approximately 3 times more often with prenatal exposure to methimazole compared to PTU. However, one has to be cautioned about the severe liver injury that is caused by PTU, where you get liver necrosis. So you have to be fully aware of that. But other congenital malformations are far more common with methimazole. So in a newly pregnant woman with Graves' disease, who is euthyroid on a low dose of methimazole, that means if she is getting methimazole less than 5 to 10 milligram or PTU less than 100 to 200 milligram, one should consider discontinuing anti-thyroid drugs given the potential teratogenic effects which I've just mentioned. However, this decision will be based primarily on the clinician taking into account the disease history, what is the duration of the therapy, what is the border size, and what are the recent thyroid function tests, and what is the antibody levels and other clinical factors. But most of them who are just on 5 to 10 may not need this in the first trimester. So following cessation, once you stop these anti-thyroid drugs, maternal TSH and FT4 or total T4 and clinical examination should be performed every 1 to 2 weeks to assess the maternal and the fetal status, thyroid status. If pregnant women remains clinically and biochemically euthyroid, the test intervals for estimating thyroid functions may be extended to 2 to 4 weeks during second and third trimester. So in pregnant women with high risk of developing thyrotoxicosis, where one needs to continue with anti-thyroid drugs, that means those pregnant women who are on more than 10 milligrams per day of methimazole or 200 milligrams of PTU, they are the ones who need to continue with the anti-thyroid drugs during pregnancy. PTU is the recommended drug for treatment through the first 12 to 16 weeks of pregnancy. Pregnant women receiving methimazole who are in need of continuing therapy during pregnancy then should be switched over to PTU as early as possible till 16 weeks. But the problem is that when you are shifting patient from methimazole to PTU, you should remember the dose ratio is approximately 1:20. That means 5 milligram twice daily is equivalent to about 100 milligram of PTU twice daily. So this is what you should remember in mind. So if the patient is on 5 milligram twice daily and you're switching over to PTU, please make it 100 milligram twice daily. Now, if you need to give anti-thyroid drug therapy, or if you need to continue with anti-thyroid drug therapy after 16 weeks of gestation, one is not very clear whether PTU should be changed to methimazole or not, as both these medications are associated with potential adverse effects, and shifting potentially may lead to a period of less diet control, which may not be good for pregnancy. So at the moment, we really do not have any recommendation with regard to switching over if the therapy is required to be continued after 16 weeks. Now, all these women, pregnant women who are being treated with anti-thyroid drug need to get their FT4 and TSH monitored approximately every 4 weeks. And anti-thyroid drugs during pregnancy should be administered at the lowest effective dose of methimazole or propylthiouracil. And you should target the FT levels to the upper range of normal. You should never give a combination of thyroxine and anti-thyroid drugs, except in rare situation of isolated fetal hyperthyroidism. So what happens if anti-thyroid drug fails to control the hyperthyroid disease? That means a pregnant woman needing more than 300 milligram of PTU or more than 40 milligrams per day of methimazole or carbimazole, one should then consider, or if the thyroid functions are still not controlled, one should consider surgery. And the best time to undertake surgery is the second trimester. Use of 134 radioactive iodine is contraindicated. And if a person has been given radioactive iodine therapy and she plans to conceive, she should at least give 3 to 6 months and consider contraception at least 3 to 6 months before she decides to conceive. However, there are no data for or against recommending termination of pregnancy after inadvertent iodine exposure. Say, for instance, somebody by mistake have had iodine 131, you still officially cannot recommend termination of pregnancy. Thank you very much. I think I am ready to answer any queries.
Thank you, Dr. Marva, for covering it so exhaustively. I mean, you've covered quite extensively. We are almost 20 minutes late, so I will just summarize in 2 lines. I mean, you covered everything. What you suggested was people who have hyperthyroidism or known hypothyroidism, they should, known hypo should increase the dose by 20 to 30. Known hyper can stop if they are taking quite low doses of methimazole or PTU. You mentioned the amount in the milligrams of the dose. And I think you very nicely went through the biggest controversy is basically with subclinical hypothyroidism. And you very nicely mentioned that if TSH is more than 2.5 and anti-TPO is positive, only then you treat. Or if TSH is more than 4, you treat. Now this discussion and this fight between 2.5 and 4, I think will always remain. Throughout the world, I think this fight remains. So I think it's better left to the clinician, I think. Above 4, certainly we need to treat, replace with thyroxine. I mean, I'm looking at the chat box. I don't see any questions specific to your talk. And under the question answer box also, I don't see any questions. So I think if you want to have any last comment, Dr. Marva, or shall I close the session?
No, I only want to add something that these days people are recommending total T4 in the 2nd and the 3rd trimesters instead of free T4, which is, I think there's a paper from Calcutta itself about how much is the increase that occurs and should be considered for total T4. So in case there is any disparity of free T4, they could consider total T4. And the increase probably in the 2nd trimester is about 35%. What the literature says, there is almost up to 50% increase in total T4, but this paper from Calcutta shows that there is an increase of about 35%. So one could consider if there is kind of a problem in interpreting free T4 data. So they could consider getting total T4 done.
Thank you, Dr. Marva. I think you've covered the topic very nicely, very extensively, and that's why I don't see any questions. So it's all clear. Back to Endocrine Society of Bengal for the last talk, and I can see Nihal there. Hello, Nihal. Good evening.
Thank you, sir. Thank you, Dr. J.J. Mukherjee, sir, and Major General Raman Marva, sir. Coming to the next talk, sir, could you please stop sharing the slide, sir? I just project the CV slide and then. I would like to invite Professor Shubhankar Chaudhary, sir, who's the Professor and Head, Department of Endocrinology, IPGME&R and SSKM Hospital, Calcutta, to chair the session. I invite Professor Nihal Thomas, sir, who's the Professor and Head, Department of Endocrinology, Christian Medical College, Vellore, to deliver the talk. Over to Professor Shubhankar Chaudhary, sir, to conduct the session.
Thank you very much. A very good evening. We are getting quite late. We have an exciting speaker and a very interesting topic on hand. Medullary thyroid cancer is not something which is very common, but it's got great interest in terms of the treatment potentials with new medical treatment modalities coming up. So let's hear from Professor Nihal Thomas.
Good evening, and thank you to the Endocrine Society of Bengal for inviting me to give this talk, and I'd like to thank my chairman as well for the introduction. I'll be talking a bit about the updates on medullary thyroid cancer and some transitions in management which have happened over the last couple of decades. So I think it's, as everyone said, late at night, and I think it's perhaps time for a bit of a bedtime story. And this is, of course, the first authentic description of goiters in English literature, as you can see from The Tempest, wherein goiters were seen in the northern part of Italy, in places where Shakespeare, in fact, wrote very frequently about them, and this is from The Tempest. So coming to my talk, I shall cover a brief introduction, a synopsis of medullary thyroid cancer and its changing shift in paradigms in terms of management, as well as the presentations over the last 20 to 30 years, something about the surgical procedures which are performed, high calcitonin levels, radiation, use of MIBG, which is now moving into a historical realm, the pathology, the diagnosis through genetics, and finally therapeutic involvement of isotopes and TK inhibitors. So as such, medullary thyroid cancer accounts for about 4 to 10% of all thyroid cancers. It is one of the uncommon forms of cancers and definitely far less common than differentiated thyroid cancers. About 30% are reported as familial or are part of a medullary thyroid cancer, which occurs as part of MEN2, or it is characterized by high calcitonin levels and has, despite the presence of metastasis, a reasonable prognosis. Treatment is total thyroidectomy, and ablation with isotopes with MIBG or lutetium can be considered, and we use calcitonin for follow-up measurements. So here I will start first with a case of a 45-year-old diagnosed to have a combined papillary and medullary thyroid cancer, had a total thyroidectomy and bilateral MRND and sternotomy. The right neck was dissected in 2008 and followed by I131 therapy for the papillary thyroid cancer in 2009. Subsequently, there was excision of the nodes on the right side of the neck. Extensive lymph node clearance was done and a right lung biopsy was also performed. At this point of time, once again, I131 therapy was done. But since the histopathology at the second location showed evidence of what looked like amyloid, genetic testing was also done over here, and a mutation in codon 918 was present, which is indicative of a aggressive malignancy, but no family history was present. She also had an isotope scan, which was MIBG negative. Subsequently, you can see the imaging over here, which has been performed, and it shows evidence of metastasis in the region of the liver, and also a few scattered metastasis in the areas of the lung. So this will give us some food for thought as to what we should do for such a patient at different steps in terms of the management. And I shall go through our experience and then come down to the index cases as far as their management is concerned. So a bit about our experience at Velo, and it consists of 2 publications over 2 periods of time, one from 1988 to 2006, wherein we had around 40 patients. And of course, with the awareness of thyroid malignancies improving and surgical expertise improving as well, in the next decade, we had double number of patients that we had in the previous 20 years. A few examples of what we had. In fact, medullary thyroid cancer, one might remember, was one of the thyroid cancers which was discovered much later, as it were, in the 1960s. And in India, in fact, it was thought about only in the late 1970s and 1980s. This is a gentleman who came early in the 1980s and was operated and was initially thought to have an anaplastic thyroid cancer because of its large size and aggressive nature from the histopathology. But subsequently, he, in fact, came for follow-up 10 years later. The histopathology was reviewed and was found to be possibly medullary thyroid cancer. And you can see over here, he's had the external beam radiotherapy and had done very well for a period of almost 15 years till his death in the late 1990s. So this is the general duration of symptoms prior to presentation, almost 2 years in our series, with a maximum of almost 12 years with a patient who had a goiter which was gradually growing over a period of almost 13 years. what proportion of patients have local metastasis? And in fact, it's quite common. Both our series, that is, the one on the right is the one published in the beginning of the millennium in 2008, and the other one in 2017, have shown that lymph node metastases are fairly common. So around 45% in the first series and about 60% in the second series, or maybe even more than that as well. So these patients, in fact, therefore live with their local metastasis and have a reasonably good quality of life until they are treated. This was another lady who presented with hypertension and previously had a scar of a thyroid surgery done about 15 years previously at another site. And she has a typical mucocutaneous neuronomas. And in addition to that, has bilateral large pheochromocytomas. And this is, of course, typical of a patient with MEN2B. So the surgical procedures which are done, and this is by the current management guidelines for medullary thyroid cancer, indicate the necessity for total thyroidectomy and bilateral central neck dissection. Medullary thyroid cancer confined to the thyroid without advanced local invasion or cervical and distant metastasis. Here is what is being done: a dominant total thyroidectomy and a bilateral central neck dissection. Lateral lymph node dissection, of course, is something which is more contentious and in some ways controversial. There are widely varying practices in the management of lateral lymph node compartment dissection, and it is generally reserved for patients with positive preoperative imaging. Therefore, if they have significant imaging which shows visible lymph nodes or an isotope scan which has shown dominant metastasis, then lateral lymph node dissection is done routinely. And of course, prophylactic lateral lymph node dissection, in fact, is not indicated now because it does not improve both the biochemical cure and does not improve either functional or cosmetic consequences. So these are the surgical procedures which were carried out in our second series on thyroid malignancy. And as you can see, an upfront complete thyroidectomy was performed in about 86%. So a good number actually had a very complete surgery. And incomplete surgery was present in about the remaining 13% or so. What about mortality? In fact, we have good data, particularly from our first series. And this was an era, of course, wherein more extensive isotope therapy and TK inhibitors were not available at that point of time. Despite the fact and despite much later presentation of disease in that particular series lasting over 20 years, death due to extensive disease or metastasis was actually fairly uncommon. So you can see over here that even in the second series, death due to the malignancy per se was an uncommon presentation and was more common in those who had relatively low calcitonin levels and high CA levels. This is the spreadsheet of the first series, which shows very clearly that at the time of our study, most of our patients over a 20-year period were in fact alive. And only one patient had actually died in that particular series. In the second series, you can see over here the metastatic rate. And once again, despite that good survival, about seven patients over here had metastasis in the lung. And of course, this progressed to later on over here. So therefore, you have 12% progressing, adding on another extra 18%. And over a period of follow-up, which ranged from anywhere from 10 to 15 years, the metastatic rate was around 30%. Now, persistent hypercalcitonemia, and of course, this was something which was thought about with greater frequency at the point of time when we did not have imaging like PET scans, etc., more than 10 to 15 years ago. And this was, of course, more evident as an occult disease wherein calcitonin levels was elevated. We know now that there's a proportion of these, of course, wherein you can have imaging positive over there. But even in this era of isotope imaging and PET scanning, we do have a proportion of patients who have persistent hypercalcitonin. So over here, we can see that calcitonin was checked in about 55% of all our patients who had a thyroid swelling prior, because suspected medullary thyroid cancer was thought about in those patients, either to the fact that there was a family history, or the patient might have had a previous pheochromocytoma, or might have had suggestion of medullary thyroid cancer due to other reasons as well, like marfanoid features. So it was seen in 55%, checked in 55%, and was significantly elevated in all those who had an underlying subsequent post-operative diagnosis of medullary thyroid cancer. So the post-operative calcitonin levels over here when checked were persistently elevated in 70% of patients, and therefore persistent hypercalcitonemia was a common phenomenon. Mind you, those were levels by and large less than 50. And you can see over here, the post-operative calcitonin values had a very wide spread and scatter in our findings in the second study, which was from 2017 to 2007 to 2018. What about survival and in relationship to calcitonin levels? So you can see over here, the no indicates those with a normal calcitonin, and yes, wherein the calcitonin levels were even mildly elevated. And you can see that there's a trend towards clinical significance in the Kaplan-Meier chart, but it tends to kind of plateau off around the 6th year. At the end of 6 years, the survival rates kind of plateau off with the regular population as well. Yeah. Now, going to the 2017 study, a very similar phenomena, around somewhere short of the 6th year, there is a plateauing, but there is a dip again over here, which continues, and about 75% of the patients who had elevated calcitonin levels are alive at the end of a total duration of around 9.5 years. Whereas if the calcitonin levels were negative, it goes according to the normal population. So calcitonin levels, if they're elevated postoperatively, can predict outcome, but at the same time, despite elevated calcitonin levels, the survival rates are not necessarily that bad or gruesome in that sense. Now, metahydrobenzyl urinary staining was what we used to do before, prior to the PET scan era. And you can see over here, we used metahydrobenzyl when we had persistent hypercalcitonemia, and a proportion of around 35 to 40% had uptake in the thyroid bed and pooling of the lungs in another 30% as well.
Professor Thomas,
yes,
I can still see your 2017 study. Somehow, maybe the slide is not advancing.
I'll reload my slides.
Okay, thanks. Would you like to stop share and again share it? Will that help?
Yes, yes. I'm just trying to get the full screen. I'm sorry about this.
Okay, okay. No problem.
Sir, you could just press the escape button, sir. You'll go out of the presenter view, and then you'll be able to minimize it and share again.
Is it back?
Yes, sir, it's back.
Yeah, can you see it now?
Yes, the Kaplan-Meier survival. Yeah.
Yeah. So this is back to the 2017 study where you can see that there was a very similar pattern in terms of the survival rates. A dip to around 0.75 or around 25% of the patients had actually passed away by around the 7th year or so, which is of course very significant. Having said that, tends to plateau thereafter, and we have the data up to around 10 years showing that these patients, even though they had evidence of local metastasis and in some cases even distant metastasis, they were able to live with the disease. So, yeah. So we used to do MIBG scans, and of course now MIBG is in fact fairly difficult to get now, but it was the only thing available in those days, and we were not doing PET scans, and therefore there was no lutetium. And you can see over here that a good number of patients in fact had pooling in the lungs and in the thyroid bed as well. And we used to use MIBG as a therapeutic adjunct for those patients who were positive. Now, what about external beam radiotherapy? And the guidelines still exist based on the work which was done by Jensen in a large series in 1990, wherein 200 patients were studied. And EBRT did confer a survival advantage to patients who had regional disease, but not those who had distant metastasis. And in fact, even the current American Thyroid Association guidelines suggest that external beam radiotherapy can be used for those who are at high risk for local regional recurrence, and offering it to patients who have extensive metastatic disease as a palliative form of treatment. So we had experience, and of course, this was based on the fact that at that particular point of time, besides external beam radiotherapy, people used to also believe that the scatter radiation from radioactive iodine treatment might, of course, also help. Though, of course, it's a practice which we do not resort to nowadays. But mind you, those patients who did have external beam radiotherapy did have a reasonable long-term survival as well, and deaths were relatively uncommon. You can see over here the follow-up rates. We did have 2 patients who did follow-up, but you can see over here that out of our 16 patients, 14 were well on follow-up. Now, here is a bit on MIBG therapy and imaging per se. We used it to identify hidden extra FIOs. Of course, now you have much better imaging. Adrenal lesions, identify metastasis and recurrences, and of course, in pre-ablative scanning. And of course, the importance of blocking with potassium iodide was also something which should have been highlighted over here, which was not done in some of the earlier cases. But we did use it for ablation of the local metastasis in addition. And you can see over here, MIBG had a 65% sensitivity for medullary thyroid cancer, wherein post-operative residue was seen in those who had elevated calcitonin levels. What about the pathology? And of course, the presence of amyloid was seen in about 60% of our patients, but was absent in about 40% of the patients whom we had histopathology done. It is not a prerequisite, therefore, for all patients who have medullary thyroid cancer. And higher calcitonin immunostaining indicates a better prognosis, as in this particular patient. Microcarcinomas with well-demarcated collections of calcitonin staining cells are seen over here. So if an FNAC was done in medullary thyroid cancer, 84% suggested malignancy or medullary thyroid cancer, which was cellular. Now let me go down to the genetics, of which a fair amount of work has been done and is a routine practice for all our medullary thyroid cancers since the latter half of the first decade of the millennium, that is around 2006 or 2007. Our first publication was back in 2011, wherein we looked at ret proto-oncogene screening in patients with medullary thyroid cancer at risk. And it was no different from that what was seen in the European publications at that point of time. And I think, of course, you need to be familiar with the fact that certain loci are important in demarcating familial medullary thyroid cancers, and other loci are important for MEN2A, which can have medullary thyroid cancer at the same time, and MEN2B. Of course, these loci over here, you can see are indicative of a familial medullary thyroid cancer, and these loci indicate either MEN2A or familial medullary thyroid cancer. So The identification has been very critical and helpful in doing prophylactic thyroidectomy, and in fact, even some patients, prophylactic adrenalectomy. And it is our protocol now that in children of parents who have medullary thyroid cancer, children are positive for a mutation, we try to perform a prophylactic thyroidectomy below the age of 5 years, and several have been done till this point of time. And of course, certain mutations like the codon 918 can predict the severity of malignancy and more aggressive forms of malignancy. So this is a publication from the International Journal of Cancer showing how the codon 918 in the early part of the millennium had a fairly poor prognosis when compared to the other forms of mutations in medullary thyroid cancer. And this is our series published way back in 2011 showing the medullary thyroid cancer mutations and the phenotypic expression in these cases. This is a family who presented with medullary thyroid cancer, familial disease. They usually have an older onset and often between 20 to 40 years when compared to the MEN2A and 2B, which are earlier in onset. The majority of the RET mutations in familial medullary cancer are germline mutations and found on exon 10 and 11 and involve particularly codon 609, 11, 18, 20, and 34. This is the family, and you can see the index case over here. And indeed, it did lead to prophylactic thyroidectomies in 2 patients. One was the granddaughter, the grandson rather, and one was a niece of the index patient. So as you can see, it was extremely useful over here. In fact, both these patients at the point of time of surgery had normal calcitonin levels. And that was the phlebogram which was found in all the patients in that particular family. Now, there's an interesting bit of information on microRNA and its impact on disease. And this was work done by my colleague in endocrine surgery, Dr. Deepak Abraham. And it comes back to the question, 28% mutation rate in patients, or maybe at best 30 to 35%, you have the RET proto-oncogene mutation, which is positive. But what about the remaining ones? And perhaps this is the answer to that question, the mystery behind why medullary thyroid cancers may still run with some frequency in families, not with a typical inheritance pattern, but there may be presence of microRNA expressions which could be responsible for causing this. And in his study, wherein he looked at phenotypic presentations of hereditary medullary thyroid cancer and sporadic medullary thyroid cancer, he found by using a quantitative PCR that there were patients who had microRNA which were characteristic to be found in these particular patients. They also predicted some degree of severity and the presence of lateral lymph node positivity in these patients. So the higher risk mutations in patients with hereditary MTC who had microRNA positivity were in fact seen in these patients. And therefore, this is a technique, though of course not yet fully clinically validated or part of regular guidelines, which may have the potential to identify a subset of patients who need prophylactic lateral neck dissection. And I'll come finally to the therapeutic adjuncts which we use now with greater frequency over here in the treatment of medullary thyroid cancer, dotatate for screening, and lutetium and the tyrosine kinase inhibitors for treating these patients. So coming now to this 45-year-old patient whom I talked about before, who had a very aggressive dual tumor of papillary thyroid cancer and medullary thyroid cancer, and the isotope scans which I had shown you, and the presence of metastasis. So what would you do in this particular patient? This patient was given lutetium as a therapeutic adjunct over here. Now, it's very important that when we give lutetium, that we need to understand that there's a good proportion of them who may not be responding. 40 to 50% do not have a therapeutic response at the first dose. You can try the second dose, but if in case it does not work by the time you have the second dose, it's not worth continuing. But in those who do have a response, and even if it's partial, we readily give the lutetium isotope on at least 3 occasions. This patient had a second dose as well and had a gratifying reduction, or at least a gratifying reduction on the isotope scan. Now, at this point of time, he did have some O residue, and the question was asked, is lutetium enough, or shall we do anything else? Well, since he did have a significant radiological residue, vandatinib 300 mg was utilized, and this led to a 69% reduction in risk for disease progression as we look at in terms of the literature. So this was one possibility that we could offer him, and since he could afford it, this was what was given. The poorer options was sorafenib and sunitinib, which may not be as specific for medullary thyroid cancer, but can also be used in these patients and therapeutically may have response in some of them. Here is another 21-year-old lady who came, was well, and had a lump in the front of the neck, which is insidious in onset. Total thyroidectomy was done, showing features which are typical of a medullary thyroid cancer. After 6 months, an ultrasound was done, and the calcitonin levels were found to be progressively increasing. Functional cervical lymph node dissection was done, and post-op radiotherapy was administered in addition. Now, an MIBG scan was done, which was negative, and after that, she was referred to us for a dotatate scan. And this is what the dotatate scan showed. It showed evidence of lesions in the liver. It also showed that the adrenal glands appeared to be enlarged, and one of the adrenals is taking up isotope. Now, the question here is, with such extensive disease, was this metastatic medullary thyroid cancer, or could this be a pheochromocytoma? And so, of course, the isotope, the biochemical tests showed evidence of a metanephrine level which was elevated in this particular patient. So what would you do in this particular patient? Her clinical condition, well, other than the fact that her isotope scans are positive, she was reasonably fit. So what would you like to do in this patient? Well, she was offered, because of her reasonably good clinical condition, in spite of the metastasis in the liver, her liver function tests were perfectly normal. She was offered an adrenalectomy for the pheochromocytoma. After this was performed, she was offered vandatinib therapy for the metastatic lesions because she was going back to Sri Lanka. The availability of lutetium as an isotope ablation was not available. So here we have a patient which categorically expresses the lack of morbidity despite long-standing disease. Well, this gentleman presented in 1997. Total thyroidectomy and lateral neck dissection was done well to 2005. Presented with neck nodes, a calcitonin which was extremely high, and refused surgery. MIBG was given 3 times. And you note over here, this is a total duration of almost 8 years, or more than that, 12 years. And the MIBG was negative with small lymph nodes. Calcitonin was still mildly elevated. So you can see over here, in spite persistent high calcitonin levels, the patient was asymptomatic. Unfortunately, around that time, he had a fall and had a cervical fracture and quadriplegia in 2011, and the calcitonin levels were elevated, and his neck nodes were larger. And his MIBG then turned out to be positive. The neck mass was larger, and MIBG was negative. So what did we do for him? This is the CT scan showing evidence of metastasis in the liver, also possible mets in the kidney. And an isotope scan, a dotatate scan, was also performed, showing evidence of metastasis in the liver. So what would you do for this particular patient? And yes, there's an isolated met in the skull in addition, but it's asymptomatic. So what's your plan for this particular patient? Well, he's already quadriplegic, but he has survived through the last 3 to 4 years with the quadriplegia. He's otherwise a functional individual doing his business. And therefore, it was discussed with him and the family members. They opted for potential lutetium treatment in his case. Now, the question over here is a philosophical one. We have seen a number of patients like this who have metastasis but live with their metastasis for many years. And the question is, does lutetium necessarily help in reducing or improving the longevity of the patient? We can't always tell a correct answer to that particular question. Okay, so these are the options. Do a DOTA scan, and then DOTA scan can miss liver lesions because of the low lesion to background ratio. You can do a DOPA scan, which can be superior in picking up some of these lesions if they are negative. So I'll come last to the aspect of tyrosine kinase inhibitors, because they are the in thing besides the isotope therapy that we offer for our patients. As you know, these enzymes stimulate tumor proliferation and are responsible also for the invasion and metastasis of the disease. So vandetanib is the first tyrosine kinase which is approved for treatment of symptomatic metastatic thyroid cancer. It's a VEGFR inhibitor, and it does not work in a couple of mutants, RET mutants, which have been identified, the valine 804M and the valine 804L, which exhibit resistance to vandetanib. Now, if you look at the studies which I've done, in fact, it gives us food for thought once again. Using these medications in treating the disease when they are clinically symptomatic is worthwhile. But just for the sake of utilizing them for causing radiological regression of tumor is not what we should be doing. Toxicities are also common, and 35% of patients required reduction in doses because of these toxic effects, which included cardiac ones like QTc prolongation and diarrhea. So the starting dose is about 300 milligrams once daily, and we need to check on cardiac status doing ECGs, periodic echoes, and the electrolytes in addition, including thyroid function tests. So now, cabozantinib was another medication which was tried. If you look at the clinical trials per se, you can see they did not seem to have a major difference or advantage over vandetanib. And in fact, in one particular study, there was a lot of bizarre gastrointestinal symptoms which are seen in some of these patients as well. So what do we do? What do we use? Well, if a patient can afford and you can procure vandetanib, that's the drug of choice. But then we have options for those who cannot afford it. And I can tell you that the results are reasonably gratifying and quite good with sorafenib, as I've shown over here, and sunitinib. And therefore, I would advocate this for patients who are clinically symptomatic with extensive metastasis. These are true medications which can be used for these patients. And finally, if nothing works, we think about cytotoxic chemotherapy. Doxorubicin and dacarbazine are the two agents with the most extensive track record, and dacarbazine has been recommended as a treatment option for disseminated symptomatic disease when isotope therapy is not possible, and the other forms of tyrosine kinase inhibitors cannot be given. So let me conclude by saying that in our series, male predominance was seen in our medullary thyroid cancer. They were a decade earlier in both our series, in the first millennium and the second millennium of this, second decade of this millennium. MEN2 or familial disease is seen in about 28 to 30% of cases. Early tumors are managed appropriately and can still present with local or distant metastasis, despite all the technology that we have now. Mutation screening is extremely beneficial in predicting and doing prophylactic thyroidectomies and adrenalectomies. Persistently high calcitonin levels always reflect disease activity. MIBG therapy can be given, but of course MIBG is now unlikely to be available in the future, and we have to fall back on lutetium treatment and vandetanib and sorafenib in addition. Long-term survival, let me remind you, is reasonable even with asymptomatic distant metastasis. I'd like to thank a lot of my colleagues, various departments, endocrinology, surgical endocrinology, nuclear medicine, the genetics done by Rekha Pai, and the biochemistry department. Thank you very much for your patient listening.
Thank you very much, Nihal. That was a wonderful story, as you would say, as it's getting late in the night, but I think it kept us all awake. And medullary thyroid cancer experience, especially the velour experience, was definitely eye-opening. And maybe a couple of take-home points would be that it can have a particularly prolonged indolent course. So just finding a high calcitonin level does not sort of need us to immediately do something drastic. Of course, following up those patients, looking at the doubling time of calcitonin and all would be important. And the next, of course, is the genetic studies, which is coming up and could well give us a handle about the likely prognosis in a given patient. Availability of newer drugs, yes, but of course, cost and availability are issues. So it has got to be discussed with the family. So I don't see any questions in the chat box. It was such a lucid presentation. Thank you, Nihal, once again. It's back to the organizers.
Thank you, Professor Shubhankar Chaudhary, sir, and Professor Nihal Thomas, sir, for that wonderful session. All good things have to come to an end, and thus we have to end today's exciting, informative, and interactive session steered by knowledgeable national faculties. If someone has missed any of today's talks, you can view the same on the Endocrine Society of Bengal YouTube channel. The videos would be uploaded shortly. On behalf of the Endocrine Society of Bengal, I thank all the faculties and audience. I thank RX Events for the technical support and Abort India for all the logistic support and for making this event a grand success. We pray for your good health. Stay healthy, stay safe. Good night.